of guys like Emmett Smith and gymnasts from the Olympic Training Center to the playground, and hopefully we'll give you some insight. I'm sure you're all aware of a lot of injuries in sports medicine. It's very common in all of the programs across the country to have a good experience in sports medicine, and therefore I don't mean to insult you in any way. I just want to refresh your minds for board questions and highlight some tricky areas that are commonly asked. And so the focus here will not be on controversy or new things, but try to focus on what I anticipate will be important for you to know for your boards and review for you, and indeed this is a review. And just like this cartoon says, my friends, this is not exactly rocket science, and therefore we'll be able to work together and go through this as we go along. And once again, you've got to remember this is sports medicine, so therefore I'll try to take you to school. The way we're going to do this is just like it's outlined in the review text and the review of sports medicine text, and that begins with the knee. A lot of questions come from the knee, and we'll focus quite a bit of time on that. There's also some lower extremity questions that are common related to sports, and we'll try to cover the gambit of those. Then we'll stand up for a stand-up break for a few minutes and then proceed with the second half, which includes upper extremity. Beginning with the shoulder, of course, and there's a lot of test questions that come from the shoulder. We'll try to focus mostly on sports medicine shoulder injuries, but of course we don't want to exclude some other shoulder pathology, including rotator cuff pathology, and we'll touch on some arthrosis of the shoulder. We'll then briefly go through the remainder of upper extremity, focusing on sports-related injuries. Now, I recognize a lot of these things have been covered in elbow and hand talks previously, and therefore just simply use it as a review, and I think it'll help you to focus on and remember some of these important aspects. Again, the head and spine injuries, some of these have been covered as well. However, once again, review is important, and make this the first of many reviews you'll do prior to your boards. And then there's some unique issues about team physicians that are important and becoming more and more important as we see in the newspaper about athletes taking certain supplements and drugs and the responsibilities you have related to that and the things you need to know, not only for the boards, but any of you that decide to take care of anybody from the high school level up. You certainly need to be aware of some of these issues. And so therefore, we'll try to keep focused and keep on the right track as we go along here. Starting then with knee injuries. You've already seen Ed McPherson tell you about this 4-bar linkage and its importance to knee stability. We're all familiar with the cruciate ligaments, which cross, of course, in the knee, anterior and posterior cruciate ligaments. The collateral ligaments include the medial and lateral collateral ligaments. What's been more focused recently is the corners, particularly the posterior lateral corner of the knee, which has been a focus of research recently and within the last several years emphasized. And I think probably you'll see some posterior lateral corner stuff on your boards, primarily because this has been a focus of interest for probably 7 or 8 years now, and more injuries are being recognized, and therefore I think that this is a good test fodder. Let's start then with the ACL. The ACL goes from the tibia to the lateral femoral condyle. Is 33 millimeters wide, or 33 millimeters long and 11 millimeters wide. It has 2 bundles. The way you remember these bundles is to remember the PCL, because the PCL is your PAL, P-A-L. And the PAL has posterior cruciate ligament, has an anterior lateral bundle. Therefore, by simple deduction, the ACL has an anterior medial bundle. So we'll go over that again when we talk about the PCL. But as far as the ACL, the anterior medial bundle, or all anterior bundles for the cruciates, are tight inflections. Anterior bundles, tight inflection. Posterior bundles, tight in extension. Both of the cruciates have a blood supply from the middle geniculate artery. Focusing then on the PCL, which has also been a subject of intense research and a lot of papers in the last decade, the PCL goes from the medial femoral condyle to the tibial sulcus to a point below the articular surface. It's longer than the ACL, almost 4 centimeters, and it's wider than the ACL. And that's why it's a little stronger biomechanically. It has 2 bundles that have been strongly emphasized in the literature. The PCL is your PAL, and the anterior lateral bundle is the key. So if anybody's doing PCL reconstruction these days, if they're doing just 1 bundle reconstructions, the anterior lateral bundle is the bundle that they're reconstructing. And the reason is because that's the one that's tight in flexion. And that's the primary function of the PCL, is to be tight in flexion. Therefore, 1 bundle PCLs are done with the anterior lateral bundle. It's tight in flexion, and the PCL is your PAL. In addition to that, the PCL has menisco-femoral ligaments that go from the lateral meniscus to the PCL or to the area adjacent to the PCL on the medial femoral condyle. Alphabetically, these are Humphrey and Rissberg. And location-wise, they are Humphrey and Rissberg, Humphrey being anterior and Rissberg being posterior. Think about it alphabetically. Again, both cruciates are supplied by the middle geniculate artery. The MCL has a very broad insertion on the tibia, and it goes quite distal. So if you ever have an occasion to do a chronic medial collateral ligament reconstruction, recognize how distal this insertion is for the MCL. It has both superficial and deep components. The Houston Clinic nomenclature calls the superficial component the tibial collateral ligament, and the deep the medial capsular ligament. The rest of the world calls it superficial and deep. The deep capsule has attachments to the menisci, which are in the form of coronary ligaments. So again, superficial, deep, and the deep actually is a capsular thickening. The lateral collateral ligament, on the other hand, is kind of short, stout, and cord-like. It is tight in extension. And therefore, if you're doing reconstructions in this area, you should postoperatively immobilize them in extension. As far as strength, the MCL is the strongest of all the ligaments. It's about 4,000 newtons worth of strength. Then the PCL, which we talked about, is thicker than the ACL, and indeed it's a little stronger than the ACL, but not twice as strong as used to be assumed. And the weakest of all is the LCL, which is amazing because rarely do we see isolated LCL injuries. And that's because they're tied up with posterior lateral corner that we'll talk about in a second. The posterior medial corner, which has had less emphasis than the posterior lateral corner but still is important, consists of layers, as we found from the studies at the Hospital for Special Surgery. Of those layers, the most important are the superficial MCL, which is actually in layer 2, and the deep MCL, which is actually in layer 3. Those of you that have had occasion to wander around this area trying to harvest hamstring tendons will recognize that the semimembranosus tendon can often be confused for some of these tendons, as can the deep fibers of the MCL. So if you're mucking around in there, look for two tendons that are coming almost horizontal and are superficial to the deep MCL. The posterior lateral corner has had an extreme amount of interest recently in the literature. Note that probably one of the most important components of that is the Popliteus musculotendinous unit. The Popliteus muscle originates in the back of the tibia, becomes tendinous right there at the area where it starts to go from the tibia to the femur. And the back of the tibia becomes tendinous, and then it inserts. And look where its insertion is in relation to the lateral collateral ligament, because this is asked all the time. So indeed, it is slightly distal, it is anterior, and it is deep or medial to the lateral collateral ligament. So recognize that insertion because it's important, and you will see it again. The patellofemoral joint can be described as having either 7 facets or just a couple. I prefer a couple, that is medial and lateral, and that's all you really need to know. Of course, the patella also has the thickest cartilage in the body, and the reason for that is because the forces that go across that are tremendous. It's a fulcrum, and it's a quadriceps moment arm, and its cartilage can be very thick. The important thing here in the literature in the last 5 years is the medial patellofemoral ligament. The MPFL is the key restraint to lateral displacement of the patella, and when somebody has an acute patella dislocation, more often than not, they will tear that ligament. And here we see the medial patellofemoral ligament in some anatomical drawings. It attaches to the medial epicondyle, just distal to the VMO. In fact, you have to reflect some of the VMO in order to expose it properly. And then attaches to the patella. Now, if you have an opportunity to do a total knee or you happen to be over in this area, then look at this ligament and appreciate that it really does exist. Menisci are very important. They're crescent-shaped. Only the periphery of the meniscus is vascularized. In younger patients, more is vascularized, and as we get older, less is vascularized. The medial meniscus is more C-shaped. The lateral meniscus more semicircular. Meniscus has a variety of functions, including deepening the tibial surface. It's a secondary stabilizer to anterior displacement, that is the posterior horn of the medial meniscus, and that fact is commonly quizzed as well. It also has a function of nutrition and lubrication. So meniscus is a vital structure, and we used to whack them out 20 years ago, and now we realize how important they are, so now we're trying to put them back in again. The meniscus has both longitudinal and radial fibers. The longitudinal fibers are important because this is the hoop stresses that occur in the menisci. And therefore, when you're doing meniscus repairs, if you can capture those longitudinal fibers, that is with vertical mattress sutures, then that's the strongest construct possible. Meniscus, like bone, is made of type 1 collagen. B-O-N-E has O-N-E in it, and therefore it has type 1 collagen. So does the meniscus. The lateral meniscus has twice the excursion of the medial meniscus, as has been shown by MRI, dynamic MRIs at the University of Pittsburgh. As far as horns attachments, the lateral meniscus, again, which is more semicircular, has attachments its horns very close to each other and very close to the ACL origin. The medial meniscus, on the other hand, has separation of horns quite a bit. So one's way back by the PCL, and one is way anterior, in fact, sometimes off the articular surface of the tibia. Next time you do a scope, look at that medial meniscus, and you may see the anterior attachment way off the anterior surface of the tibia, and therefore the anterior horn medial meniscus tear, if you have 10 of those on your oral boards, perhaps you should rethink which ones you're going to throw out. As far as physical exam, we're all familiar with the important physical exams, and we're also important history. So if you'll be given a history, just like in the pathology, you'll be given an exam, and don't jump to conclusions until you've had a chance to sort through all of it. So of course, if somebody has a non-contact pivoting injury with a pop and immediate swelling, then 70% of the time, they'll have an ACL tear. 70% of acute hemorrhagic effusions are ACL tears. If somebody has a blow to the tibia, for example, with a dashboard, then think about PCL injuries. If they fall onto their leg and their foot is plantar flexed, then the force will be transmitted through the tibia as well, and they may have a PCL. If, on the other hand, their foot is dorsiflexed when they fall, then the force goes to the patella, and they may have a patella contusion, patella fracture, or patella injury. Patients who have classic mechanical symptoms, including locking, think about meniscus tears. If patient has pain with stair climbing, then you think about patellofemoral problems, and I try to get them out of my clinic with the least amount of crying. Now, again, key physical examinations are important, and although some examinations are asked more often than not on OITs and boards, it's important to know the key ones in particular and then have some idea about the other ones. For the ACL, the key exam is the Lockman exam, done at about 30 degrees of flexion. From a practical standpoint, it's helpful to just simply stick a pillow under the patient's knee, and that'll allow them to have it in about 30 degrees of flexion. It also allows them to relax their knee while you do their exam. And so if you allow the patient to tense their hamstrings, then you won't get a good exam. And so if you'll simply put a pillow under their knee, rock their knee a little bit with your hand that's towards the head, if you'll feel the hamstrings and make sure they're not tensing them, then you'll get a better lockment. The pivot exam is helpful also, pivot shift or pivot jerk. It's more helpful for an exam under anesthesia. In the clinic, you'll only be able to do that one time. As far as the PCL, the key exam is the drawer, that is the posterior drawer. And the key to the posterior drawer is to assess the starting point. Feel the medial tibial plateau in relation to the medial femoral condyle. The normal medial tibial plateau should jut out about 1 centimeter from the medial femoral condyle. You can feel it on your own knee. If your tibia is flush with your medial femoral condyle and goes further back when you push it, come see me afterwards. As far as the PCL, another exam that's frequently quizzed, especially in the OITE, is the quad active test described by the late Dale Daniels. What this test is you have the patient lie supine with their knee flexed as they would for a posterior drawer, and you stabilize their foot and ask them to kick out. As they kick out with your stabilized hand, their tibia will sublux anteriorly and reduce. And if you can demonstrate that, that's the quad active test, which once again is done in flexion. The knee starts sublux posteriorly and then reduces as it moves anteriorly. The medial collateral ligament is tested for isolated tears at 30 degrees of flexion. A simple valgus stress will tell you whether it opens or not. The same thing with the lateral collateral ligament, varus stress at 30 degrees. Now, if that opens at both 30 and 0 degrees, then you have a combined collateral ligament injury, and probably at least one of the cruciates are injured, and therefore you have a multiple ligament injured knee. The posterior lateral corner is best assessed with the patient prone, in my opinion, and looking for external rotation asymmetry, a disparity of more than 10 to 15 degrees in the thigh-foot angle. In other words, the foot rotates out more on one side than it does on the other. You can also do a variety of other tests for that, including external rotation recurvatum, posterior lateral drawer, and a variety of other tests. But the key, I think, is the external rotation asymmetry, and this is what's been borne out in the literature. As far as testing for meniscus pathology, meniscus tears, the key is joint line tenderness, simply palpating along the joint line. And a provocative maneuver can help benefit this, and that includes McMurray testing, which is flexion and rotation, or aptly compression test, where you have them lay supine and push on their foot and compress the meniscus, or something as simple as a duck walk, which is kind of entertaining to do in clinic anyway. As far as patellar femoral pathology, look for apprehension as you try to sublux their patella laterally. If they have apprehension, perhaps they have patellar instability. Here we see external rotation asymmetry with the patient lying supine. This is done at 30 degrees in this case. You can also do it at 90 degrees. So with it at 30 degrees, if you see external rotation asymmetry, then you perform the same test at 90 degrees of knee flexion. If the asymmetry persists, in other words, if they have it at both 30 and 90, you need to be suspicious of a combined posterior lateral corner and PCL injury. If it's just at 30 and not at 90, then you may indeed have an isolated posterior lateral corner injury, or a posterior lateral corner injury with an ACL. Then you flip the patient back over and do your Lockman and drawer to verify it. This is the reverse pivot shift. It's only important because I want to emphasize one thing with all these pivot shift questions that are asked on boards. The key with all of these examinations, all these pivot shifts about trying to figure out what's reduced and when it's subluxed, is just remember with a PCL deficient knee, your tibia is subluxed in flexion, and that's the whole problem. And so it reduces in extension, but it's subluxed in flexion because that's where the injury is. With an ACL deficient knee, the knee is subluxed in near extension because the ACL is not functioning. It should be reduced in extension. So as you're trying to figure out these answers, just remember that concept. This lower diagram shows the quadriceps active test described by the late Dale Daniels. Once again, the patient tries to push his foot out. As he does so, you've restrained it, and the tibia will start from its subluxed position and reduce. Subluxed, reduced. Now, there's a variety of imaging clues that will help you with diagnoses. The key with these imaging studies is that it may be difficult to see them on your x-ray that you're given on your boards. And we've all seen the OIT diagrams where you can't see anything on them. So if you don't see anything on the x-ray, then ask yourself, is there a patella there? Is there something subtle I'm missing? And look indeed, and more often than not, if you don't see anything on the x-ray, either the patient has no patella or the patella is way up high riding, patella alta associated with patella tendon rupture or something like that. So look for the patella if you don't see anything else, if nothing else is obvious to you. Also, you may see a Sagone fracture, which is a little tiny chip off the lateral aspect of the tibia, highly associated with an ACL tear. If you see that little chip, then you can say with confidence the patient has an ACL tear. However, as we know, very rarely does an ACL tear actually have a Sagone fracture. So if it's there, you think you have an ACL tear. If it's not there, it doesn't mean you don't have an ACL tear. If you have calcification up here in the medial femoral condyle, that's called Pellegrini sciati, and it's highly associated with a chronic medial collateral ligament injury. Patella alta either means patellar instability or patella tendon rupture or some other variety of conditions. But look for the patella. If you have Fairbanks changes, that is squaring, ridging, and narrowing, and then we all know sclerosis often is associated with that, but Fairbanks didn't describe it, that's associated with arthritis from post-meniscectomies. And as you get more and more arthritis, then you become less and less a candidate for any soft tissue procedure. If you have Osteochondritis Dissecans, that classically occurs the lateral aspect of the medial femoral condyle. If you have widening or cupping, then you think about a discoid meniscus. Well, we also can do stress radiographs, and these are becoming very important, particularly in evaluating PCL injuries. So you probably need to be able to recognize these series of slides on the right and figure out which one of these has a PCL injury. And so hopefully you'll recognize that this tibia is subtly subluxed as opposed to this one. Now also stress radiographs may be helpful for evaluating kids with injuries, and that is trying to figure out whether they have collateral ligament injuries or they have physeal fractures. And so this is an important test to do. Additionally, sometimes it's helpful with a multiple ligament injury knee. You don't know which side's normal. We have the global instability, and therefore it's sometimes helpful to put some lead gloves on and an apron and go into the x-ray suite and stress the knee and figure out what's going on. So we will not uncommonly, at least once at a clinic, do a stress radiograph of a patella or a medial collateral ligament or, of course, PCL with a machine called a Toulouse machine. MRI, of course, is excellent. It also can classify and identify ACL-associated bone bruises, which are osteochondral injuries. The location of these bone bruises is commonly asked as well, and if you remember this x-ray right here, you'll remember where the bone bruise is. Because this injury right here, when you have an ACL tear, many times you will actually sublux or almost dislocate your knee, and the back of the tibia impacts upon the middle third of the lateral femoral condyle. So remember that picture. Remember it's the middle one-third of the lateral femoral condyle, and it's in the lateral tibia plateau, posterior one-third. This occurs with ACL injuries, and that's the classic bone bruise. Arthroscopy, of course, is the mainstay of a lot of our outpatient procedures, and we're all familiar with the various portals. Inferior lateral is the primary viewing portal, inferior medial the primary probing portal. But there's a variety of portals you can use. The literature has borne out that a posterior portal is often very helpful for looking at the posterior horn of the medial meniscus. And the way that is created then is you simply drive the scope into the back of the knee. So once again, you take your scope and you simply push it into the back of the knee right along the medial femoral condyle. You may need a blunt probe for this sometimes. And then look to your right. When you look to your right, you'll see this posterior horn of the medial meniscus. For those of you that have never seen this, perhaps you should go back and try to figure out how to do this. You put the scope in again along the medial femoral condyle, pop through the back, look to the right. You may want to use a 70-degree scope at this point, and you can see the posterior horn of the medial meniscus. Then when you're back there, you simply take your finger and poke on the capsule and poke on the medial side of the knee and see where your finger will make an indentation. Take a spinal needle and put it in and locate where your portal will be. And then if you want to establish a portal there, go ahead and make a small incision, a nick and spread, so you don't injure the saphenous structures, which are right over that area. Nick and spread, put a cannula in, and you can look then with your scope, take your scope out of the knee and put it into the back, and you can see the posterior horn of the medial meniscus very well. So next time you're in a cadaver lab or next time your attending's out of the room, try this little trick, and you can see the posterior horn of the medial meniscus. Now, as far as meniscus tears go, this is the most common injury in the knee requiring surgery. The medial meniscus is torn more than the lateral meniscus on a chronic basis. However, for acute injuries, lateral meniscuses are cropping up more often, particularly with combined ACL injuries. So there's two flavors of meniscus tears. One occurs in young people, the other occurs in older people. The younger people have a longitudinal tear that is amenable to fixation, that is repair, and older people will have a complex tear or degenerative tear of that meniscus, and that usually requires resection or partial meniscectomy. Be careful from a medical legal standpoint whether you call something a degenerative tear or a complex tear, because you may get in a work comp situation where somebody has a complex tear of a degenerative meniscus that occurred as a result of an injury, and yet if you just call that a degenerative tear, it doesn't commute the same information to that person or that carrier. And so you'll have a lot of fun with the insurance companies over your career, but just be careful on that one issue. If you can repair the meniscus, repair it. If you can't, if it's irreparable, such as some of these degenerative flaps tears and some of these complex tears, then you need to do a partial meniscectomy. It's not a debridement, it's a partial meniscectomy. And so what you do is try to minimize the amount you take out. You reduce just the amount necessary, because the more you remove, the more likely the patient is going to get arthritis down the line. The other thing that is strongly discouraged in practice, and particularly on the boards, is using thermal probes around the knee, because thermal probes for the articular surface have been shown to cause chondral injury, and thermal devices around the meniscus also have a zone of injury associated with them. It may not be as big as the thermal injury, but there's still a zone of injury associated with it. Now, let's go into meniscus repair. The key about meniscus repair is that the redder it is, the more closer to the periphery, the more acute it is, and the fact that it's longitudinal, that has the best chance for repair, and therefore you should repair all red zone tears. Now, as the tears go more closer to the center, they become less peripheral, then the repair success diminishes. Nevertheless, red-white tears are repaired, particularly associated with ACL reconstructions, and I would encourage you to select that as the right answer. So, We know that if you do a combined ACL reconstruction, there is an enhanced ability for that meniscus to heal, whether that's because of factors that are released at the time of ACL reconstruction or whether that's because an ACL-associated meniscus tear is more amenable to repair. We don't know. But the point is to recognize that ACL reconstruction and meniscus repairs do well. There's a variety of techniques. Keep in mind that the gold standard, and the old guys writing the board, the best technique is the vertical mattress suture. So even though you may be firing arrows and darts all over the place, don't forget that vertical mattress sutures is the strongest. And the associated injuries with those vertical mattress sutures, because small incisions are necessary, is injury on the medial side to the saphenous nerve or saphenous vein. And again, these are asked all the time on quizzes. Saphenous nerve, saphenous vein on the medial side, and the lateral side, the common peroneal nerve. And you say, well, how could you possibly injure that? It's way back there. Well, believe me, you can. I've seen it. And so what you need to do is you go posterior to the lateral collateral ligament and in front of the biceps tendon. And dissect and make sure your retractor is in front of the biceps tendon. Because as we know, the peroneal nerve comes around the back of the biceps tendon. And as long as you're in front of the biceps tendon and you visualize the needles as they come out, then you're not going to have a problem. Now, all of the newer devices have new problems associated with them. And the old boys writing this board are very happy to try to pound these into you and ask you questions about them. And so recognize that even though they're fast and quick, there's been a variety of case reports over the years talking about problems associated with these devices. And therefore, to recognize this, and they include breakage, migration, synovitis, chondral injury, and decreased strength compared to vertical mattress sutures. So be aware of all those. And indeed, independent assessments have shown that the double vertical mattress or even single vertical mattress suture is stronger than these other devices. So we're looking for a fifth-generation device. It's bioabsorbable, strong, low profile, efficacious, and doesn't injure the cartilage. And unfortunately, we're still looking for that, and therefore it won't appear on your boards. So if you see this in your practice, then I'd recommend you do this. And this is a demonstration of inside-out meniscus repair. Now, meniscus transplantation has become very controversial, and indeed it even has a T code in the coding book, which means it's investigational. But still, for patients that have total meniscectomies, particularly on the lateral side, because the meniscus is so necessary on the lateral side because of the convexity of the tibia plateau, then it's still a reasonable option, but you need to convince the insurance company of that. Because it's technically difficult and the long-term results are unclear. The key issue, the controversy here is you certainly do not put this in a patient that has grade 4 chondrosis. Once you get to grade 4 chondrosis, or even some people say grade 3 chondrosis, it's like sandpaper scraping off your new meniscus. So this is not a good procedure for somebody with grade 4 chondrosis. And also it's important to make sure the patient has good mechanical alignment before you put it in there, because if you put it in an overloaded compartment, it will wear away. So from a technique standpoint, on the medial side we use bone plugs, on the lateral side you use a bone bridge, such as this, and then peripheral sutures, again, inside out. Second looks have been very good, but the question remains whether they function normally. Moving on then to meniscal cysts. Meniscal cysts used to be whacked out in block with a big incision on the side. Nowadays, and this has been in the literature for several years now, and therefore is good test fodder, meniscus cysts can be addressed arthroscopically because they're almost 100% of the time associated with a horizontal cleavage tear of the meniscus, and typically the lateral meniscus. So what you do is you go in and do an arthroscopy, you do a partial lateral meniscectomy, and then you put an instrument that is a small shaver or a basket or what have you in between the leaves of that meniscus tear, and you can decompress that cyst. And as you push on the outside, you can actually see the fluid emanate from the cyst into the joint. And so you decompress it in that fashion. You can also stick spinal needles from outside in and visualize as the cysts decompress. So meniscus cysts, much like spinal glenoid notch cysts in the shoulder now, can be decompressed through, in this case, the meniscus, and in that case, by debriding the labrum. So we'll talk about that later. Discoid meniscus, the key exam question here is, you see this beautiful discoid meniscus as you're lollygagging through the knee looking for something to do for your scope so you can code something on the CPT chart, and you see this. Well, leave it alone. So if you have an asymptomatic discoid lateral meniscus, leave it alone. If you have a tear, that's a different story. and then you can do a partial meniscectomy, in this case saucerization, or making it look like a normal meniscus because you're taking out the tear. So they come in 3 flavors: incomplete, which is a partial discoid meniscus; a complete, which covers the entire surface, as this example does; or a Risberg variant. A Risberg variant is called other things some places in the literature, but basically what it means is that it's a meniscus, whether it's discoid or not, it's a meniscus that doesn't have any coronary ligaments. So it has no attachments to the capsule, and therefore the treatment for that, as you can imagine, is to give it some attachments to the capsule by doing a meniscus repair. Do an inside-out meniscus repair, and you give that a stability to that Risberg variant meniscus. Now, that pretty well describes it. I think the key thing here from exam standpoint is discoid meniscus, you see it, it's asymptomatic, then go do something else because you need to leave that meniscus alone. Let's go on to OCD, Osteochondritis Dissecans. OCD is a term that's thrown around all the time, and it may mean osteochondral defect in an adult, but in this case, Osteochondritis Dissecans is a childhood disorder, or it's sometimes an adult order, and that most often is a manifestation from childhood that's left over. So we have 2 forms, juvenile form and adult form. A juvenile form means the physis is still open, so we caught it before the physis closed. Those have a better prognosis. Once the physis closed, the prognosis goes markedly down, and that's because probably it's been around for a long time and it has no more chance of healing because the physis is closed. The key test questions here: the location, burn this in your brain, lateral aspect of the medial femoral condyle. Now, the treatment then depends upon what the piece looks like. If the piece is stable, then maybe you just need to debride it a little bit. If the piece is unstable, then you need to detach it, clear up the bed, and ideally reattach it. If it's not reattachable, that is, if you have to throw it in the bucket, then there's a variety of other things you can do. And for the board purposes, they won't make you choose amongst those. You'll just need to debride it or do some kind of chondral treatment to that, and they'll probably leave it at that. They avoid controversy in the board, so they're not going to get into which. If there's several techniques or treatments that are both all efficacious, they'll avoid making you choose amongst them. So then this then leads us into osteochondral or focal osteochondral injuries. That is, areas where the articular cartilage has been injured and has a defect. Now, I'm not talking about diffuse arthritis where all the cartilage is thinned. I'm talking about focal discrete defects. In those cases, there are a variety of treatment options that I've listed here, and again, there's enough controversy here that they probably won't ask you particular ones to use. Just recognize that these are ones that are available, including abrasion or some type of chondroplasty. That includes the microfracture, which is a fancy way of doing a drilling. Plugs, of course, oats, mosaic plasty, and core. Chondrocyte transplant, which is ACI or autologous chondrocyte implant or transplant. It's popularized by Swedish surgeons, and then a variety of other grafts. So usually just they won't get into exactly what to do in what case, but they'll ask you to do a chondroplasty, and that's fine. Now, there's 2 types of osteonecrosis you need to be aware of in the knee. One is the classic osteonecrosis or atraumatic osteonecrosis, which is associated with alcoholism and Caisson's disease. And if I ever get this, I'm going to tell them I'm a deep sea diver so they don't think otherwise. And the treatment here then is core decompression, just like it is in the hip. And as it gets more advanced, you need to do a knee replacement. There is another unusual osteonecrosis that hadn't got the press that the atraumatic one has, and that's the so-called sulk. So if you have a patient who had a meniscectomy, middle-aged patient had a meniscectomy, comes in and is just having pain way beyond proportion you think they should have, and you think that they're just an old crybaby, then maybe they have sulk. And what that means is that it's a subchondral insufficiency fracture that occurs, and it commonly occurs in that kind of setting. And so if you throw that patient back in the MRI scanner, you may see that they have sulk, and the treatment for that then is to put them on crutches and give them a few months, and they'll get better. Now, I know Dr. Parsons talked about synovectomy, as did Dr. Foster, for those of you that were brave enough to hang around. And therefore, it's important to recognize that this can also be done arthroscopically. And with arthroscopic synovectomy, it can get just as good of results as an open synovectomy, provided you use additional portals. So you can't just use your standard inferior lateral, inferior medial portal and expect to do a complete synovectomy. You've got to also go back to the back, the way I showed you, I taught you earlier, put that back in the back and use that posterior medial portal. And if you're really bold, a posterior lateral portal as well, Make sure you stay anterior to the biceps. And you can clear up all the synovium, and you have to go up to the top, the patellofemoral joint, and clear up all that synovium as well. This also applies, and I think this is rarely done, but I think it's important to do, if you have an infected knee. If it's been percolating for more than a few hours, you need to go do a synovectomy when you're washing out a knee. A knee washout with a scope is not a correct term. You need to do a synovectomy as well, because if you don't, the knee will persistently remain infected. So any of you who have treated post-op ACLs that got infected or some kind of other knee problem that got infected, and you go in and you wash it out and you barely even look in there because it's the middle of the night and you just stick a couple cannulas in and wash through a bunch of liters, that ain't going to work. And that's why those patients have to go back 2 or 3 times, because you need to remove the synovium. So I'll get off my soapbox for that. Now, speaking of synovial lesions, these also include plica. And plica is nothing more than a thickening of the joint lining. And most commonly, this involves the medial plica, the medial patellar plica, and this can abrade the medial femoral condyle. Now, it is not as pathologic as CPT reporting would suggest that it is, and in fact, rarely should you actually do this as your sole procedure in the knee. These are over-reported, overdone, and they're not quite as mean and vicious as many people that do them would suggest. And therefore, if you're going to your second part of your board exam with 10 plicas on your list, you better rethink it. Now, let's go to ACLs, which is stuff we love talking about. This is a result of a non-contact pivoting injury. There has been a marked increase in the female athlete, and the reason for that is because of a variety of factors, including some issues about the way that female athletes have historically landed when they're jumping. And so we've been teaching them to land with their knees flexed and less valgus, and this is reducing the injuries across the country. And so it's remarkable that this intervention is happening. When people have ACL injuries, they'll have a quadriceps avoidance gait. That's not important to actually know what that means except to answer it on the test question. And again, the key exam is the Lockman. We still treat a few ACLs non-operatively, that is the low demand and less laxity patients. Fortunately, they don't end up in my clinic very often. And more often, we're doing operative intervention for higher demand and active patients. As far as graft choices go, recognize that the patella tendon and the hamstring tendon are considered equally efficacious these days in America, and in fact, they both represent co-gold standards, if you will. However, the question that is always asked is that the patella tendon graft has a higher incidence of anterior knee pain. The issue about hamstring deficits following harvesting of hamstring graft is kind of in 2 camps. Some people say they have weakness, some people say they don't, and so it's too controversial for them to get into too much. But this is not controversial. That is, patella tendon grafts have a higher incidence of anterior knee pain. Even though the hamstring graft, when you test it in the lab, is stronger and stiffer, it's not as strong initially because of the fixation devices. So when you're fixing soft tissue, even with the use of some of the newer devices, it's not as strong as the traditional bone-to-bone fixation using interference screws. So that's the other advantage of patella tendon, is that it has a better initial strength and with the fixation, and that's why we do it in our young adult male athletes such as NFL football players, because we can't trust them in the early rehab period. The other grafts that are becoming popular include quadriceps tendon graft and also allografts. With allografts, I'd shy away from that answer on the boards, again, because who's writing the board questions. Recognize there's a variety of risks with allografts, including, of course, HIV, hepatitis C. There is delayed incorporation time of those grafts in animal studies, and a variety of other issues. And so allografts, I'd say, are pretty much fallen out of favor, particularly for primary reconstructions. Now, preconditioning these grafts, such as on this board here, can reduce stress relaxation, and that's important because you want to reduce that before you get it in the knee. Complications of ACL reconstruction most commonly involve tunnel placement. Fortunately, this is becoming less of a problem as people get more clued into where this belongs and as people go to more courses. Again, we'll go over tunnel placement, but typically in the community, these are sometimes placed too anterior, causing graft failure. Another problem that's also fortunately being minimized is the risk for stiff knee afterwards, and that has been minimized by more proper technique, that is putting the grafts in the right place, and also by physical therapy, working with them, and also working early on getting full extension. And the other issue is not operating on patients when they have acute injuries. Most people will delay until the effusion has gone down. The one exception is the state you're currently in. All right, so loss of motion then includes preoperative issues, and that is getting their range of motion early, making sure their effusion's under control, making sure they have good quad tone, make sure they have a reasonable gait without a significant limp. And if those things are all met, and that typically is about 3 weeks before you're following the injury, then it's appropriate to proceed with an ACL reconstruction. But I would encourage you not to do ACL reconstructions acutely in your practice because it can cause you this problem, which of course is an unsolvable issue late. Recognize that if you have a combined MCL injury or patellar dislocation, that these people are at significant risk for loss of motion postoperatively, and you need to get your therapist and yourself on them right away. Other issues involved with loss of motion include tunnel positioning, tensioning of the graft, reducing post-op hemarthrosis by ice or even some people with a drain, working on early range of motion, including extension, having the nurse put a pillow under their heel, not their knee, and then a variety of other factors. Fractures following a patella tendon rupture, the Jerry Rice diagnosis, can occur between 8 and 12 weeks postoperatively. You can reduce this incidence by using a smaller saw blade, by cutting the undersurface of the patella, by drilling at the corners to reduce the stress risers, by making less rectangular and more trapezoidal grafts, and by bone grafting your defects. If you have tunnel osteolysis, this is likely to come up because it's becoming a big problem, and that is that you get a post-op x-ray several months or years after your ACL reconstruction, and you see this giant area that is basically osteopenic and is full of fibrous tissue. That has not had a clinical effect on the graft. However, it drastically impacts your options for revision surgery. And so that's the key issue there, is that you need to address that at the time of revision surgery. A cyclops lesion is nothing more than a proliferative tissue that's left over and hypertrophies, and it's often at the base of the ACL, and it can affect extension. And so the treatment then is to debride that, and you'll achieve your full extension. So all this issue about tunnel placement, the problem is the tunnels have been placed too anteriorly historically, and so when the tunnels are placed anteriorly, you have increased strain in flexion. That is, no matter whether it's the femoral tunnel or the tibial tunnel, if you have tunnels anterior, you have increased strain in flexion. And that makes sense back to our Powell concept, and if you think about that, you'll understand that. And so again, if the tunnel is anterior, you have strain in flexion. Again, the tunnel anterior is measured by Blumenstadt's line, and this is what Steve Howell has taught us. If you draw a line down from Blumenstadt's line, when the knee is in extension or even hyperextension, your tunnel should fall posterior to that line. This graft is unimpinged. This graft is 100% impinged and doomed to failure. ACL shrinkage, this is not a good idea. Recent articles suggested that if you treat goat or dogs, they did this. They shrunk normal ACLs on one side, left the other ACL untreated. 8 weeks post-op, all 18 of those dogs had ruptured ACLs. So if you're using this device for this ligament, then you're going to be doing a lot of revisions. Now, PCL injury, again, occurs as a result of a blow to the tibia. Again, the key exam is the posterior drawer. Treatment includes ORIF of bony avulsion. So back to the boards we go. You look at a picture, you can barely make it out, but there's a piece of bone in the back of the tibia. You go, wow, what do I do about that? Well, the answer is ORIF in all cases. There is no controversy about that. If there's a bony avulsion of the PCL, the answer is ORIF. Now, if you have an isolated PCL injury, here's where the controversy comes. In fact, it's really controversial because you really need to discover whether it's truly isolated or not, and this is what we've evolved in over the last 10 years, is to figure out that most of the so-called significant isolated PCL injuries weren't isolated at all. That is, they also had a combined posterior lateral corner injury. So again, how do you figure that out? Well, you do the external rotation asymmetry test. You do the posterior lateral drawer test, see if it dials rotary as well as posterior. If that's the case, that's not an isolated PCL. And again, if it's a combined injury with not an isolated PCL, there is no controversy. If it's a combined PCL posterior lateral corner injury, those need to be fixed. And so you fix the posterior lateral corner either acutely or chronically with a graft. and you fix the PCL at the same time. No controversy about either bony avulsions or multiple ligament injuries with posterior lateral and PCL injuries. The controversy involves the isolated PCL. The isolated PCL, I don't think there is any controversy because all of us treat that non-operatively, and therefore the answer for the test is non-operative. Now, as far as ways to do this, it includes a tibial inlay, which is, of course, my preference, and then two bundle techniques, which can be combined with either the transtibial or the inlay. And so here we see the classic example of the inlay, which we can talk about later, but as far as test purposes, this is not important. What is important is postoperatively to immobilize the knee in extension, protect it against gravity, because gravity is your enemy. It will make the tibia sublux posteriorly. And emphasize quad rehab because the quadricep will pull your tibia anteriorly. And so those are the key concepts from the test-taking standpoint. The other issue is that this concept about two bundle reconstructions, and two bundles include, again, your PAL, the anterior lateral, which is most important for the PCL, and therefore you do that in all cases. And then the question is whether you also do the posterior medial. And the posterior medial bundle will give you some added benefit, but there's controversy about how much. And we only know that it does in the lab and not necessarily in practice. So the inlay has less graft attrition. This has come out in the literature recently because it doesn't have to go around this killer turn, if you will. But the two bundles has better stability, at least in the lab, and also not only in extension, which you'd think because that's where it functions, but also in flexion, which is a little bit surprising. Moving on to MCL injuries. MCL are a result of a valgus contact injury. If it's just an isolated tear, it'll only open at 30 degrees, and these are always treated in a hinged brace for 6 to 8 weeks. They don't make you get into this controversy about how many degrees of flexion you have to put it in for how long and then change the flexion. All you have to know is you put it in a hinged brace, and everybody across the country for isolated MCLs treat this with a hinged brace for 6 to 8 weeks. There is no controversy here. 6 to 8 weeks hinge brace. It's when it's combined with ligament injuries that there may be some controversy. Lateral collateral ligament. I have never seen an isolated lateral collateral ligament injury, ever. And I've been looking. And so this is rare if it even exists. Even though it's amazing because this is the weakest of all the ligaments, only 700 to 800 newtons, and yet it's rarely injured by itself. But if it were, it would be injured by a varus contact, and there'd be varus opening, just like the medial side, and then the treatment, at least, would be bracing, just like it would be on the medial side. But again, these are more often associated with posterior lateral corner injuries, and those are diagnosed by the external rotation asymmetry and then addressed at that time. Posterior lateral corner injuries should be addressed ideally within 2 weeks of the injury because otherwise the tissue scars and becomes difficult to identify and impossible to fix. And so here we are with a posterior lateral corner injury, and it looks like a bomb went off on this young man who simply was playing football. And so the problem with this is we used to not recognize it, and I don't know how we couldn't recognize this, but we didn't. And only within the last 10 years have we recognized this. And again, it's because of external rotation asymmetry. So again, the treatment then is to recognize it and then treat it and try to do primary reconstructions if you can. And more often than not, you need to back that up with some kind of static graft placed either through the tibia or the fibula and up to the lateral femoral epicondyle. Again, primary repair, acutely. You may need to supplement this for the best results. So-called two-tail or three-tail options using hamstring grafts and a popliteal fibular reconstruction. Multiple ligament injuries, also known as knee dislocations. You need to rule out a neurovascular injury by checking for the perineal nerve, that is dorsiflexion of the foot. Document that before you get to the OR, and document that on paper and write it down and make sure everybody knows that that nerve's injured, because if it gets injured later and you didn't document it from the beginning, then that becomes a medical legal problem. Also, you need to get your vascular surgery boys involved and at least consult them because there's a high incidence of arterial injury, and so you should encourage them to get an arteriogram, which will identify that and need to be addressed accordingly. Dislocated knees or multiple ligament injured knees are based upon the placement of the distal structure, that is in this case the tibia. Anterior dislocations are more common than posterior dislocations, which are more common than lateral dislocations. The treatment for a knee dislocation is to reduce it and then address the neurovascular structures and get the swelling under control, observe them overnight, make sure they don't get compartment syndrome, send them home, and have them come back electively for reconstruction within 2 weeks of their injury if they have collateral ligament or posterior lateral corner injuries. If they just have ACL, PCL, which is very unusual, then those can be addressed at some time later. Now, the other thing that's important from a knee standpoint and sports medicine standpoint is to get some concept of bioabsorbable materials, okay? So you need to know what the rates of absorption are for some of these devices, because we always throw in bioabsorbable screws, but the real issue is how absorbable are they, and you need to know that. So PGA with a SureTac, this absorbs in a matter of 4 to 6 weeks, so it only hangs around for a month. And that's why when you use a SureTac, you're supposed to immobilize the patient for an entire 4 weeks, not to let them move at all, because the thing gets weaker as it goes along. So if you're using SureTacs and you're trying to get their motion early, that's probably a mistake. PDS, which is polydioxane suture, its material is also used for some of the newer meniscus repair devices. This can absorb in months. PLLA absorbs, that's what's used for bioabsorbable interference screw for your ACLs. Well, some of these are showing up 5, 6 years after ACL reconstruction, and some people are wondering whether they're absorbable at all. They're certainly radio opaque, but they may not be bioabsorbable. And therefore, there's a whole bunch of research going on to put some of the D isomer in there, PLDA, or putting some PGA or PDS in there or something else, and to try to affect that absorption. And that's where we stand with bioabsorbable materials in 2003. Proximal tib-fib joint can be dislocated, usually on a flexed adducted knee. If it happens, it's anterior lateral dislocation of that joint. And the key issue here that is asked is what do you do after you reduce it and you immobilize them in extension. So just about any question in the knee on the boards, if you can't remember what position to immobilize them in, then pick extension and you'll probably be right. Overuse injuries, tendinitis, bursitis, iliotibial band syndrome, these are all treated with non-operative stretching, strengthening, conservative measures. And so if you get into these kind of questions, then you've got to go out of your way to make sure that they've exhausted all of their non-operative measures before you pick an operation on the boards for these kind of overuse problems. Once again, rehab, rehab, rehab. As far as RSD, like so many things in orthopedics, we think we've figured this out by simply renaming it. So now this is called complex regional pain syndrome. And we still have no clue why it happens or how it happens, but we've got a new name for it, which is nice. And so the key here is patients have pain out of proportion to what they should have. They may have skin changes, temperature changes, osteopenia. The treatment and the diagnosis is done by a sympathetic, that is an epidural block. Treatment and diagnosis, epidural block, sympathetic block. Extensor mechanism injuries. Older patients get a quadriceps rupture. Younger patients get a patella tendon rupture. This occurs in basketball players. You've all seen it. The key is to make sure that they don't have extension. They don't have any extensor mechanism function, and then you'll recognize this. You'll get fooled sometime in your career thinking this is an ACL tear. But again, go back, look at your x-rays, see the patella is displaced proximally, and say, oh my goodness, I almost missed that. Patellar fractures, if it's displaced, then you need to treat it, and you fix it with classically with AO technique, wires and tension band technique. Patellar dislocations, again, recognize the medial patellofemoral ligament and its role, and there's controversy about whether to do anything about first-time patellar dislocations. For the boards, I would say that you would only remove loose bodies and not address the SIMPFL on primary dislocators. If you have recurrent patellar instability, then, of course, again, the treatment, rehab, 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 and failing this, then you'll only consider realignment procedures. And the key realignment procedure, of course, is a Fulkerson. Fulkerson not only medializes, but it anteriorizes the tubercle, and that's why it can be a benefit. The contraindication to a Fulkerson is superior medial patellar arthrosis. So if you look into the scope and he's got grade 4 arthritis superior medially, then don't do a Fulkerson. As far as lateral patellar compression or tilting of the patella, you need to make sure you have objective evidence of tilting, that is radiographically ideally. If it doesn't tilt, you shouldn't do a lateral release. So lateral release, like Plica excision, has been done too much in this country, and this is not the last thing you do so you can find something to put on the CPT document. This shouldn't be done that often. And again, if you go to your parture boards with 10 lateral releases, think again. So patellar chondrosis, or arthritis of the patellar joint. Again, if you do a compression test, they'll feel pain there. They may have an effusion. Radiographs will demonstrate narrowing. The treatment, again, for all these patellar things is rehab, rehab, rehab. And failing that, then either some type of tibial tubercle elevation, a la Fulkerson or modified Fulkerson with bone graft, or a McKay procedure where you elevate the tubercle and put bone graft behind that is the appropriate choice. The McKay operation got a bad name because of skin changes and problems, because McKay's original description, he had you elevated an entire inch, and you can imagine the skin problems with that. So if you just do it a centimeter, then this works out. And this actually, even though it's considered a salvage operation, has been beneficial in a handful of my patients. Again, you shouldn't be doing more than a handful of them over several years. Patellofemoral syndrome, the bane of our existence, involves pain with stair climbing, theater sign, where they sit for a long time and it bothers them. They have pain with compression. Again, the treatment is rehab, 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 closed chain, short arc, quad exercises, and hopefully they'll go to somebody else's clinic. As far as pediatric disorders, again, OsgoodSchlatters involves the tibial tubercle, Signing Larson-Johansson at the distal pole, and the treatment again, rehab, 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 rest, activity modification. They used to throw kids in cylinder casts for this, and now we don't do that. Back to pediatric injuries, again, stress radiographs, important to identify Salter-Harris injuries. And these are important because you need to counsel the parents that unlike Salter-Harris injuries in the rest of the body, these can have disastrous sequelae, including growth disparity and growth problems. Ligament avulsions, bony avulsions of the tibial eminence should be treated if they're displaced. And these can be done with a variety of techniques, including sutures, either done arthroscopically or open, or even screws. Be careful you don't use a screw to cross the physis. Other problems include popliteal cysts, and people will come into your clinic all the time complaining about this Baker's cyst, and their primary care physician has referred them to you for their Baker's cyst. And they're so focused on this cyst that they don't understand there's other problems in their knee, and so it requires some counseling to explain to them that more often than not they have a complex or degenerative tear of their meniscus, and that cyst is a result of that. Therefore, you take care of the intra-articular pathology, and the cyst will usually resolve. Bipartite patella is of interest because it simulates a fracture. It occurs most often in males, and it's not often bilateral, so the people think you should just get an x-ray of the other side and make sure it's there too. It's not really a reasonable thing because it's really uncommon for it to be bilateral. And it's just basically an unfused ossification center, and you just observe it. Now, very rarely, if it becomes a problem and you look in the scope and you see there's a step off, then very rarely we excise those, but I would say for the boards, you just leave it alone. So let's ask a few knee questions. What I'm going to do here is I'm simply going to go through the odd questions quickly and leave the evens for you later. Before we do that, let's talk about wrong answers when you're answering questions about the knee. First of all, the wrong answer is indiscriminately ordering an MRI, even though that's popular in our culture. If you have an exam and a history that goes along with appropriate injuries, we don't need an MRI despite what the media suggests. Other wrong answers in indiscriminate injections of steroids in the knee. Diagnostic arthroscopy, that is, having to put a scope in to figure out what's going on because, again, your history and physical should have made that clear ahead of time. There's no such thing as an ACL repair. We do ACL reconstructions, but, again, we don't do those acutely. You don't initially operate on treatment of PCL injuries, especially isolated PCL injuries. And then initial operative treatment of patellofemoral or overuse problems is not done because they have to have rehab. So, starting with the odd numbers. Which of the following statement best describes the tension of the components of the PCL? Well, the PCL is your pal. It's tight in flexion. Anterior lateral band, which is your pal, is lax, becomes tight in flexion. And the posterior medial is tight in extension and becomes lax in flexion. Skipping 2. Number 3. College football player twists his knee, attempts to tackle a player. Exam shows no medial laxity or joint line tenderness. Anterior and posterior drawer tests and pivot are negative. But the Lachman's positive. Well, how is that possible? I thought if you had an ACL, you had an anterior drawer test positive. Well, this question is emphasizing the fact that the anterior drawer is of historical significance only and of importance only to make sure you don't have a PCL injury because the gold standard for an ACL is the Lachman. ACL injury, Lachman. Skipping 4, number 5. 13-year-old quarterback feels a pop in his knee. He's being tackled. Radiographs and Lockman are normal. He has tenderness over the distal femoral physis. What do? Stress radiographs, because you want to make sure you don't have a physeal injury. Skipping 6. Number 7. What part of the meniscus has the highest incidence of degenerative tears? Or, if it's a work comp injury, that's called a complex tear. Which part of the meniscus has the highest incidence of that? Posterior horn, medial meniscus. Number 9. Palpable joint line cyst in the knee, meniscal cyst, is commonly associated with horizontal cleavage tears of the lateral meniscus. 13-year-old boy complains of knee pain and swelling following training lessons for ski racing for 6 months. He has an OCD with open physis. What kind of OCD does he have? He has juvenile OCD. He only has an effusion, so what do? Activity modification and see him back in a couple months. He doesn't have very much symptoms. Just have him back off on his skiing. He still has open physes. We're going to treat this conservatively because as long as he has open physes, the prognosis is good for juvenile OCD. What type of gait pattern characterizes a patient with an ACL deficient knee? We don't even got to know what it looks like. It's a quadriceps avoidance gait. Physical examination of soccer player, knee injury, grade 3 ACL, MCL, and lateral meniscus. He has the new O'Donoghue triad, which used to be ACL, MCL, medial meniscus, and now more commonly we recognize the terrible triad involves ACL, MCL, lateral meniscus. So, if you're going to delay ACL surgery until a patient has full pain-free range of motion, will decrease the risk of arthroplasty. So put him in a hinge brace in the meantime for that MCL. 23-year-old football player, hyperflexion injury to the knee, has a pop, can't bear weight, has a hemarthrosis. What does he have? Hyperflexion injury. PCL and sports injuries can be a result of hyperflexion injury as opposed to MVAs when they have dashboard injuries. So hyperflexion injury, as described by Pete Fowler in sports injury, can be associated with a PCL tear. Which of the following best describes the relationship of tibia to the femur during a positive reverse pivot shift? And you're going to say, I'm just going to skip this question because I never understood this question. And so again, think about when the tibia is reduced and when it is subluxed. It's a PCL injured knee, and therefore the tibia is subluxed posteriorly when it starts in flexion, and then when it goes to extension, it reduces. Okay? So it's really not that hard. Just think about what the pathology is and where it would be subluxed because a PCL deficient knee is subluxed in flexion. 21. 32-year-old man swelling his knee, falling with the knee flexed and his foot in plantar flexion. Where have we heard that before? Foot in plantar flexion. So what's getting contact with the ground? The tibia. Lockman, apparent increase in anterior translation. Well, they're getting fooled because that's not anterior translation. They're starting from a posterior subluxed position and pulling it to its normal position. This happens all the time that people miss PCLs with Lockmans and because they think that they don't understand the starting point. And so how do we assess the starting point? Put the knee in 90 degrees of flexion and palpate the relationship of the medial femoral condyle and the medial tibial plateau. If you will get in the habit of doing that all the time, you will never miss a PCL. You may miss a patellar dislocation, though. All right, so the neurovascular exam is normal. This patient has a external rotation that's symmetric. That means that he doesn't have a posterior lateral corner injury. So he's got an isolated PCL injury. What is the non-controversial treatment for an isolated PCL injury? Non-operative management. Okay, that's the only option here where it was a non-operative option, and that's why that's the right answer. Cadaver studies show that alteration in joint line kinematics or joint kinematics following PCL ligament leads to, well, this is the so-called Fujifilm studies where they demonstrated increased contact pressures and therefore late arthritis with chronic PCL insufficiency in the patellofemoral and medial condyle or medial compartment. Medial and patellofemoral compartments. Okay? 25. Which of the following findings in an exam is isolated posterior lateral instability of the knee? Let's see. External rotation asymmetry. Was it 30 or was it 90? It was just 30. 25-year-old man struck by an MVA sustains an injury to his right lower extremity. Every person that has a pediatric, motor vehicle versus pedestrian accident Pedestrian always loses. Radiographs show a posterior dislocation in the knee. However, exam reveals the limb is neurologically intact. Well, what do we do about that? Close reduction, and then consult your vascular people. 26-year-old marathon runner. These people are difficult in clinic because they always want to push it too much. And so I tell them that God made us to go out and get a bison and drag it back to our cave, and that's not 26.2 miles away. So he's had pain with running, has an Ober's test. Where have we seen that before? Ober's associated with iliotibial band syndrome, running hills, okay, classic iliotibial band syndrome, and indeed that's what it is. What is the most common clinical indicator of complex regional pain disorder? That sounds good there, huh? Disproportionate pain, pain out of proportion to what it should be. What is the most appropriate indication for a lateral release in the knee? Well, I'm going to my board and I need 10 cases of it. Where is that? Objective evidence of lateral patellar tilt. Failed therapy has tilt. 35. 6-year-old, medial fossal pain, has a Baker cyst. You put a needle in it, comes back again. What do you tell the folks, the parents then? These spontaneously resolve. You don't need to do anything about these in the pediatric population. Okay, let's move on then to lower extremity. Groin pain in athletes is a difficult area. You'll see a lot of this in the training room, and it's tough to get a good handle on this. They have pain at the extremes of exertion. It happens almost exclusively in males, and it may involve a very subtle hernia that your general surgeons will think you're crazy that you sent them to because they don't have any obvious hernia, but there's subtle disruptions of the pelvic floor, and we're still trying to figure out the best treatment for these, but in some cases they've done well with pelvic floor repairs. Snapping hip can be either external or internal. If it's external, it's the iliotibial band or iliotibial tract that pops over the greater trochanter. Again, all of these treatment initially is conservative, but if you can observe that, and you can do that by doing a bursogram to rule out the internal type, and if that rules out and you still have the problem and you can feel it sometimes, and you fail conservative management, then you can do a Z-plasty of the iliotibial band. Now, the internal type, as you extend the hip from a position of flexion, abduction, external rotation, you will get popping. And here you put the needle in the iliopsoas bursal, you have your musculoskeletal people do it, and they'll see this kind of phenomenon, which is demonstrated with the dynamic test, where you can see the iliopsoas popping over the femoral head. And on arteriogram, on that bursogram, you'll also see this figure of 8 that happens with the bursa because it gets constricted by this. Then, failing, again, conservative measures, you can do a series of lengthening where you just basically make some cuts partway through the tendon to lengthen that tendon, kind of like a la PEDS surgery. And then you can also have snapping hip from labral tears or loose bodies, which can be diagnosed by arthro MRI of the hip. Other hip disorders include subluxation or dislocation, a la Bo Jackson, and these have a high incidence of osteonecrosis and go on to devastating problems in athletes. Arthritis can occur in runners over time, and the key thing, the key exam issue here, and this appears all the time on exams, is that the first thing they lose is internal rotation. So if you're suspecting hip arthritis, the first thing that's lost, the first motion that's lost is internal rotation. Hip scopes, you can take care of loose bodies, labral tear, synovitis. You can either do it lateral decubitus or supine. Both are well accepted. And the portals are immediately adjacent to the greater trochanter, either just in front of it or just behind it. And also there's one that's on a line from the ASIS and over to the trochanters, and it's basically in the middle of the thigh. And so, again, you do the nick and spread method, and it's quite deep. And if you use blunt obturators, you'll avoid injury to the femoral nerve. So stress fractures involved overuse problems. Bone scan is still helpful in making this diagnosis, as in MRI. And the key issue here is if you diagnose a stress fracture, to have the patients do activity restrictions, cross-training, which most often involves a swimming pool or elliptical trainer. There are certain problem fractures involved, and they include the femoral neck stress fractures, which sometimes need to have fixation, the anterior tibia, which may have a dreaded black line, which means that there is a horizontal line in the midshaft of the tibia and the anterior cortex. If you see a dreaded black line, those have a propensity to go on to fracture, and therefore you should do a tibial rodding of those patients. Tarsal-navicular is also notoriously a problem with stress fractures, and that is treated with non-weight bearing. Tibial stress syndrome, you can see some changes in bone scan. Again, it's simply an overuse thing, as is the anterior tibial stress syndrome, and those treated with rehab, send them to somebody else. Exertional compartment syndrome, patients will classically have pain that occurs 10 or 15 minutes after they start their exercises. They have to rest for 10 or 15 minutes or longer for it to go away. You make the definitive diagnosis with compartment measurements while they've done a treadmill, and then if they failed other methods of treatment, then a fasciotomy is indicated. The key thing with the fasciotomy is you have to be very careful because you barely open your scissors, you bluntly dissect ahead of time, and it's a blind technique, and therefore you have to be careful and know what you're not going to injure. Barely separate your scissors and make sure you palpate and retract as much as you can, and don't cut vital structures. And here we are doing a fasciotomy on the lateral side. I go 12 centimeters above the tip of the lateral malleolus because this is where the superficial peroneal nerve comes up, and you very carefully dissect and push the scissors up here, push the scissors down here, and the same thing on the lateral. So you do the anterior and the lateral through one incision here laterally. On the medial side, also an incision, and again, you've got to get both superficial and deep. This incision is right behind the tibia, and that way you can palpate on the back of the tibia to make sure your deep compartment is released, as well as your superficial compartments. That is not a home run operation, and so I counsel the patients very carefully that there's often concomitant pathology like stress syndrome or stress fractures or overuse things, and I tell the patients very clearly, and more importantly their mothers, that they may not get complete relief, and we're going for a base hit and not a home run in that operation. This is a weird bird, popliteal artery entrapment syndrome. The artery can be contracted by the medial head of the gastroc. If they have claudication and you can demonstrate it to vascular studies, then you can do a surgical release. Nerve entrapments, as they are throughout the body, can occur wherever there's fascial defects or where they're crossing certain areas. The superficial peroneal nerve can be entrapped in that same area we were just talking about in compartment syndromes. 12 centimeters proximal to the lateral malleolus, and you can feel a defect, a hernia there of the muscle. And so the treatment of that is simply just like exertional compartment syndrome, to isolate that, protect the nerve, and then just simply open up that area a little bit bigger. The Baxter nerve, the foot guy will tell you about this, is a common popular question because it's the nerve to the adductor digiti quinti, and it gets entrapped in this fascia for the abductor hallucis. Jogger's foot, the medial plantar nerve gets entrapped, and if you give these people an arch support, that's the wrong answer because it makes it worse. So if somebody's having medial foot pain with running, you give them an arch support, and that's the wrong answer. Muscle injuries can occur at anywhere along the muscles, and that's why hamstring strains can occur all the way from the butt all the way down to the knee because of the different muscle bellies that are located. Quadriceps contusion, the key thing about this is the only exception to the immobilize and extension rule is if you have a significant quadriceps contusion, a bruise in the quadriceps, you should immobilize these people the first night in flexion. And that's from studies done at West Point and a follow-on study at West Point showing the same thing. So that's well documented in the literature that if you have a quadriceps contusion, those patients need to be immobilized the first night in flexion. Now, the so-called tennis leg used to be thought that it was a rupture of the plantaris muscle, and of course that's crazy because you go in to do an Achilles tendon rupture, and what's the only thing that's left is that tiny little plantaris muscle. That dude is just as strong as the lateral collateral ligament. And so a tennis leg then doesn't involve a plantaris rupture. It involves a medial gastroc injury most commonly. And these can come in a variety of flavors, and some kind can be debilitating for quite a while. The one exception to the treating the hamstring non-operative rule is a proximal avulsion. If you can identify this early, and if the patient typically has an injury where they're water skiing and they're and they hyperflex their hip, then if you can identify that, that's the one setting where early repair of hamstring may be appropriate. You put it back down to bone at the ischial tuberosities. Myositis ossificans can occur following a blunt trauma, and the key issue here in the tumor question becomes what is a tumor and what is myositis ossificans, and to recognize for MO, the mature bone is at the periphery and the unmature bone is in the center. If it's the opposite, you got to worry about osteosarcoma. And again, the treatment then initially is rest and then active motion, not passive motion, but active motion. And that's asked on the OITE all the time as well, and perhaps the boards. Variety of tendon injuries, and again, we'll discuss this briefly, but the foot doctor will give you a little more information about this. Peroneal tendon subluxation is what ruined Barry Foster's career at Pittsburgh. And again, if they pop out with eversion against resistance, then you need to stabilize this. It's stabilized typically by either a groove deepening procedure or ideally an anatomical procedure that restores this cartilaginous ridge in the back of the fibula that holds in the peroneus tendons. Longitudinal tears in the tendons usually involve the brevis, and the foot boys like to put some fine sutures in there because they're trying to mimic hand surgeons. Posterior tibialis ruptures, this occur in older athletes. Again, if it's significant, you need to whack that part out and stabilize it by transferring those tendons. FHL will also be injured in dancers when they're on point. This is a very stressful position for the foot in dancers, and they get a whole bunch of problems as a result of that. And they have posterior medial pain. The key here is this right here. For a FHL injury in a dancer, they have decreased great toe passive extension in neutral, but when you plantar flex their ankle, they have normal great toe extension. And so that is diagnostic then of FHL tendinitis or tendinosis in a dancer. So remember that. Achilles tendinitis is just overuse. You rest and you do therapy like all of the tendinodisises. And in fact, the new edition of Clinics in Sports Medicine coming out this month it is on tendinosis. And this tendinitis thing is going to fall out of our literature, and it's all going to be tendinosis in the future. Ruptures then occur with maximum plantar flexion. The patient will have typically a basketball player, and they feel like somebody shot them in the back of their heel. And indeed, they have to limp off the court. You squeeze their calf, and they have asymmetric flexion of their foot with squeezing the calf, and then you need to treat it. And this closed treatment is associated with a high rate of re-rupture, approaching 18%. Open treatment, which is most commonly done, there can be a risk of wound problems. I used to say that I'd never seen wound problems, although I've been unfortunate enough to see some recently. And so you need to be careful with managing the tissues and immobilize them in plantar flexion after your operation. I had a guy that had to go on an airplane trip, and so I decided I'd let him move a little bit because I was worried about him getting a DVT, and that was a mistake. So don't do that. All right, os trigonum, this little piece of bone right here impinges when the foot is in maximum plantar flexion. It's hot on a bone scan, and the treatment after failed non-operative measurements involves excising that little piece. The same thing, other os that you need to be aware of is a os subfibulaire, which is a little piece of bone off the bottom of the fibula, and this can be associated with chronic ankle instability. And this association, not the treatment, but the association, is what you need to be aware of. Ankle sprains, of course, very common, the most common injury in sports. Most often involves the anterior talofibular ligament. It occurs with the foot in plantar flexion. The calcaneofibular ligament is also injured very commonly, and they can be both injured. But classically, the calcaneofibular ligament is injured with the foot in dorsiflexion. And so again, the treatment involves palpating and stressing, and then make sure they don't have a so-called high ankle sprain. And a high ankle sprain means a syndesmotic injury. And so the way you rule out a syndesmotic injury is to squeeze the calf and see if they have ankle pain, to externally rotate the foot or see if it goes up the back of the leg. And if you have a syndesmotic injury, that's important to your coach, and it's important, therefore, to you, because you need to tell them that the athlete will be out more than just an ankle sprain. It's not a normal ankle sprain. It's a high ankle sprain, and the coaches know what that means, and it means their athlete's going to be out longer than a conventional ankle sprain. The so-called Ottawa ankle rules define when you need to get an x-ray in the training room. And so if they have tenderness in the distal part of the fibula, you've got to rule out a fracture of the distal fibula. And this is if the patient can't walk also. If they have the tenderness at the base of the fifth metatarsal, thinking about a Jones fracture. If they have navicular tenderness, classically a fracture that's hard to see and also doesn't do well unless you treat it with non-weight bearing, then you need to get an x-ray on those things. Otherwise, you can blow off the x-ray that night. Now, as far as getting a radiographs, you need to get plain radiographs, and then sometimes you need to get stress radiographs if you're concerned about a syndesmotic injury and disruption of the mortise. Again, look for mortise widening on these stress radiographs. MRI can be helpful, looking primarily for either perineal tendon pathology or osteochondral injuries as shown here in the talar dome. Ankle sprains are treated with rest, ice, compression, elevation. Some people say price, protection, rice. Surgery, if it ever gets to it, is only after extended non-operative management. Never suck into operating on a ankle sprain on your board exam until you've tried extended non-operative management. And then the best procedure is an anatomic procedure called a Brostrom procedure, which basically involves imbrication of the capsule. So anatomic procedures are favored on the boards. Sometimes arthroscopy can be helpful following recurrent ankle sprains with impingement and synovial hypertrophy or scarring, so-called meniscoid lesions. So the real issue involves telling this coach when your patient can be back, and it depends upon the degree of injury, whether you have a high ankle sprain, whether you have associated injuries, and how the rehab's going. And so for acute ankle sprains, they're thrown into three categories: minor, partial, complete. Depends upon the instability and what's torn. Whether they have a syndesmotic sprain, again, squeeze, external rotation, Cotton test, which basically just toggles it, testing for some stability. Syndesmotic injuries take longer to recover from. Associated injuries, OCD, perineal tendon injuries, fractures, chronic ankle instability. And so the answer to this question then, how long is my athlete going to be out? Well, if he has a grade 1 or 2 sprain, maybe just a week or two. If he has a grade 3 sprain, a few weeks. If he has a syndesmotic injury, several weeks. If he has severe syndesmotic injury or needs surgery, he's out for the season, coach. Sorry. Okay. Now, there's a variety of procedures for ankle instability. Again, I'd recommend the modified Brostrom procedure. All of these other procedures that use tendons to root around, you probably don't need to do that. Here you see the concept of modified Brostrom, just like a capsular shift, you're reducing the volume in that joint. These impingement lesions, by the way, this is just down the road in Colorado Springs. If you want to see the Olympic Training Center, it's pretty cool. Involve these type of injuries, and again, these respond to rehab, and failing that, arthroscopy. Bassett was the first one at Duke to describe this impingement using this anterior-inferior tibiofibular ligament, and he did ankle arthroscopy in Debrimont. There's a variety of other injuries, including the so-called posterior medial impingement lesion. Again, it's just hypertrophy, and it responds to arthroscopy. And the so-called meniscoid ligaments, so 3 different varieties and flavors of these. Again, chronic swelling, pain, and fibrosis following ankle injuries, and you can do an arthroscopy and debride that. Here we see such a case. Here's this lesion in this inlaid arthroscopic picture, and you simply debride this with your shaver, and you're on your way. You can prevent ankle injuries with arthrosis and with conditioning programs. Moving on then to fractures. If you have a hip fracture, it's commonly called a skier's hip. It's treated like any other femur fracture. All these fractures are treated just like LaCroix taught you, except we have cute little sports names for them. For example, the lateral process of the talus occurs often in snowboarders, and so it's called a snowboarder's fracture. Osteochondral injuries, these involve the talar dome. The medial talar dome is the most difficult to get to because these injuries occur more posterior and they're deeper lesions. So therefore, they've developed these techniques where you can drill across a malleolus or take off the malleolus to get access to it. And so the medial things are hard to access. The lateral ones are easier because they're more superficial and more anterior. Ankle arthroscopy, the key here is to recognize the injuries that can occur and the nerves that are around this area. It's like elbow arthroscopy. Ankle and elbow arthroscopy are asked primarily on boards to know about what nerves can be injured. And so therefore, let's go through this. Portals, the anterior lateral portal is located between the hold on a second. The anterior lateral portal, the key issue is to worry about the superficial peroneal nerve, which comes out in this area. The anterior medial portal, you got to worry about the saphenous vein. So therefore, those are important concepts. And let's go back to this. This portal, therefore, is between the peroneus tertius and the superficial peroneal nerve. And therefore, the superficial peroneal nerve is what we're concerned about. And the superficial peroneal nerve, as you know, comes out 12 centimeters above the lateral malleolus and sneaks on down here. And therefore, if you'll stay right in that interval, and you can sometimes palpate it, but perhaps more importantly, do the nick and spread method. Make a tiny nick and spread with a hemostat. As far as the anterior medial portal, do it between the tibialis anterior and the saphenous vein. The saphenous vein commonly gets injured on the medial side. In fact, I remember one case in particular when I was here at the Air Force Academy, and we were doing a case, and we let down the tourniquet, and blood just started gushing out of this medial portal. And everybody's congregating at the door and looking in, and there's this blood pool forming on the floor. And I said, put the tourniquet back up. And that's what we did, and the show was over. But you got to be careful of that. All right. The other issue is the posterior lateral portal or posterior portals. The posterior medial portal is explicitly avoided primarily because of risk to the artery back there. The posterior lateral portal next to the Achilles tendon, and again, you got to worry about the sural nerve and the short saphenous vein back there. So that's what's important with ankle arthroscopy, is not so much doing it, but worrying about nerves. Metatarsal fractures, the second metatarsal occurs in ballet dancers, also in recruits that are doing march, and they call it march fracture. And the fifth metatarsal base occurs in athletes. And the test question here is that operative treatment can return that individual to training earlier than non-operative treatment. Turf toe involves a hyper dorsiflexion injury of the great toe, and it injures the plantar sesamoid complex. And it is amazing how many athletes who had their careers injured or ended as a result of a turf toe, including Deion Sanders. Late, then you can get hallux rigidus or arthritis of that joint. So again, using the same concept, we're going to go through some questions in the lower extremity, first emphasizing what's wrong. Again, steroid injections, initial operative treatment of sprains and strains, and aggressive management of recreational athletes as opposed to competitive athletes. So back to that fifth metatarsal fracture treatment, you have to establish whether that patient's a recreational athlete like you and me, or whether they're a competitive athlete. If they're a recreational athlete, they get crutches. If they're a competitive athlete, they get a screw. So again, using odd numbers, 17-year-old boy runs cross country, 6-week history of anterior medial leg pain, persists after running. And so how are we going to figure out what's going on with this guy, and what does he have? Probably has exertional compartment syndrome, so we're going to put some needles in there on the treadmill and see what he's got. 25-year-old competitive runner, progressive pain in the medial arch. Pain in the medial arch. Let's give him an arch support. What do you say? He has compression in the medial plantar nerve, so you do not want to give him arch support. Which of the following rehab methods should be used for the first 24 hours following a blunt injury to the quadriceps? West Point study. Mobilize the knee in flexion. 3 months, 35-year-old man, pain in the posterior medial ankle when running. He has tenderness. Passive extension of the great toe is greater when the foot is plantar flexed. Now, where have we heard that before? So you don't even got to know exactly what it is, but if there's something about the great toe and there's something about it when it's plantar flexed versus not plantar flexed, that's good enough to know that that's FHL tendonitis or tendinosis. 9, 31-year-old woman, instability of the right ankle for 10 years. She has stress radiographs showing asymmetrical anterior drawer, lateral opening. Os subfibulaire, what's that? Well, we told you that's associated with ankle instability, chronic ankle instability, and that involves a little tiny bony piece of the distal fibula. So this patient's been putting this up for 10 years. She has os subfibulaire. What does that mean? Well, it means non-union of avulsion fracture of the fibula, probably from the ATFL. A 17-year-old boy steps in a hole. His ankle is in dorsiflexion. What gets injured with the ankle in dorsiflexion? CFL, as opposed to ATFL, which is in plantar flexion. 13. Radiographs 20-year-old athlete sustained injury to his ankle, no fracture, no widening of the mortise. He has swelling in the ankle. What do we do to confirm the diagnosis? We want to make sure he doesn't have a syndesmotic injury. How do we figure that out? External rotation stress radiograph. Which of the following nerves is most commonly injured in arthroscopy of the ankle? That lateral portal. 18-year-old recreational soccer player, pain in the lateral foot for the past 4 weeks. Fracture of the base of the fifth metatarsal. Recreational. Here we go. Recreational. Okay? Sorry, buddy. Competitive. Competitive athlete. Proximal shaft fracture of the fifth metatarsal. Competitive. He can get a screw because he returns earlier to training. What is the most common sequela of turf toe late? Hallux rigidus. Okay, so that represents the end of the upper extremity. I want everybody to stand up for a few minutes, take a little break, and then we'll go on to the next section. Yeah. Yeah, they do. Okay, we need to get going again. I'm sorry. I'd like to give you a longer break, but we got to finish this other section up by 9:30. A lot of very thoughtful questions, and I appreciate that. One thing I wanted to bring up to the group was this hip fracture. Once again, the tension side, the top side, is the one that has to be fixed right away. If you have a compression side only, you can observe that, and only if it involves more than less than 50%, you can observe it, but it can go on, and therefore you have to follow it closely. So most people will fix prophylactically tension side stress injuries of the hip and observe compression side stress injuries of the hip and observe them closely. All right, so let's move along. We're going to go into shoulder injuries. Again, starting with anatomy and biomechanics. Of the glenohumeral ligaments, the most important and the most tested in the history of test taking is the anterior band of the inferior glenohumeral ligament complex. This anterior band occurs time and time again, and so if you're ever asked a question in the upper extremity, the answer is anterior band. That applies to elbow as well. And so the anterior band, as you can see right here, is like a hammock, and it tightens up with abduction and external rotation, or cocking of the shoulder. And the anterior band shown here goes and inserts into the labrum, and then therefore if you have a Bankart injury, you have an injury not only to the labrum but also the anterior band. And so the anterior band is a key component of this essential lesion. The posterior capsule, on the other hand, is very thin and doesn't really have any ligaments. And that's why if you have posterior instability, it's more difficult to treat sometimes because this tissue is very thin. The labrum itself acts as a chalk block and anchors the anterior band, as I indicated. The biceps long head up in the superior portion of the glenoid has been a subject of significant controversy in the recent literature because of slap tears. And what represents a slap tear to one person versus another person is so variable that it has caused a great deal of trouble. The joints involved in the shoulder include not only the glenohumeral joint but also the sternoclavicular joint, the acromioclavicular joint, the coracoclavicular ligaments associated with that, the scapulothoracic joint from ribs 2 to 7, and the key test question here is the ratio of glenohumeral to scapulothoracic motion is 2 to 1, or it may be asked in this fashion, it is 120 degrees to 60 degrees. So that's an important test question. Static and dynamic restraints keep the shoulder stable. Note, of course, the shoulder is not very constrained, unlike the hip, and some people have made the analogy of it being like a golf ball on a tee. And so, therefore, you have to rely upon other restraints, including articular congruity, negative intra-articular pressure, and this is most evidenced when you see a fracture, and you'll see somebody that has a fracture and you'll see their head is depressed quite inferiorly. The reason that happens is because they have ruptured their capsule and all that negative intra-articular pressure has gone out, and that's why their head is subluxed. You'll also see that if you look at cadaver and you put an 11 blade in it, and you'll see the arm go down. The other key static restraints, of course, we've already talked about are the glenohumeral ligaments and the all-important anterior band of the inferior glenohumeral ligament. Dynamic restraints include primarily the rotator cuff musculature. We love this little picture here in sports medicine, and these 5 phases of throwing have been very well characterized. Recognize that the late cocking phase can cause anterior instability and also internal impingement, which basically is a disease pathology that involves some degree of micro instability anteriorly and also pinching of the posterior aspect of the labrum and rotator cuff. What you do about that is another controversy. And then the follow-through phase, as you can imagine, stresses the posterior capsule. One of the keys with evaluating shoulder injuries is the patient age. If you have young patients like Wally or the Beaver himself, then perhaps you have instability. Ward, on the other hand, you have to worry about rotator cuffs, arthrosis, or fractures. And then the other issue is the mechanism of injury. If you have a direct blow on your arm, we play in racquetball, you run into the side of the court, then you may have an AC injury. If you have an anterior shoulder instability, may be associated with an abduction external rotation force, where somebody rams their arm or their arm's back like this, or they go up to try to make a dunk and they miss it, and that can be associated with anterior instability. If older patients have night pain, they may have a rotator cuff injury. If you have patients who are weightlifters, then they have this weird thing called distal clavicle osteolysis, where they get osteopenia and cysts in their distal clavicle. And you tell them to quit weightlifting, and they say, forget about it, so you go in and whack out their distal clavicle. Other injuries you've got to recognize just by looking at the patient. These include winging, dislocations, separations, and looking, of course, for special tests that we do in the shoulder, including tests for impingement, which, of course, the impingement sign, the impingement test, the Hawkins test. Looking for signs of apprehension. Abduction external rotation causes them to be apprehensive. You push on their arm or relocate their arm, that goes away. And then there are provocative tests for a variety of these disorders. So let's go through a few of these. Here we have apprehension in the classic Hoppenfeld manner. Here we see Joe relocation test. This patient is much happier and much prettier as a result of doing the relocation maneuver. You can do a drawer test either in anesthesia or in your clinic. And you should do a sulcus test looking for multiple directional instability. Look at this defect here. This patient's arm was probably down by her elbow. Her proximal humerus is down by her elbow because it creates this huge defect in this patient that has systemic hyperlaxity and multidirectional instability. This is a patient that came to my clinic recently with this problem. Here's his normal shoulder, and here is the most amount he can externally rotate with his good shoulder. He's already seen an ER doctor and another orthopedic surgeon. What is his diagnosis? They never got an X-ray lateral radiograph. He had a locked posterior dislocation of his shoulder, and I'll show you some films what we did for him later. Also, you can do a jerk test. You passively move the arm across, it jerks posteriorly, or what's even more remarkable is you move the arm back, it jerks back anteriorly to reduce, and then a posterior drawer test as well. Here is the area that is the most significant problem that we have, trying to figure out who's got a slap tear. An article in This Month Arthroscopy goes through 7 tests to try to figure out whether they're indicative of labral pathology. Guess what? None of the 7 show it. So you've got to use a combination of tests and then maybe MRI and then arthroscopy, but MRI, arthroscopy tests, there's no gold standard, so nobody knows what the deal is here. So this is a big mess, and therefore probably not going to be emphasized too much on the board. But if patients do have biceps tenderness with bicipital groove tenderness, with a Speeds test shown here, O'Brien's test is similar, where their arm starts in the pronated, and it's painful, and then when they supinate their arm, it's less painful, similar to the Speeds test. Crank test is nothing more than trying to put your fingers there and crank the arm and see if you can get the biceps to pop. But there are no perfect tests for slap tears. This is a very common test question, is this lift-off test. This became so popular on the OITEs that they'd ask it 2 or 3 times in the same OITE. And what it involves is they want to emphasize you understanding the injury of the subscapularis, which most unfortunately occurs probably most commonly iatrogenically after somebody's done an anterior shoulder procedure and they didn't put the subscap back properly. When that happens, it ruptures, and therefore the patient will have a positive lift-off test. You put the arm in this position, you tell the patient to keep it there, and boom, it falls forward because they have no subscapularis. Or you have the patient pull out towards you, and they're unable to because they're so weak. Those patients who have a subscap injury will also, as you can imagine, have excessive external rotation on that side because they have no restraint to external rotation because the subscap is ruptured. The subscap injury can also be identified sometimes on MRI because the biceps will sublux medially because the subscap has a role in holding the biceps in its groove as well. So subscap ruptures are very, very commonly tested. This patient here has a pectoralis rupture because he's got axillary webbing, an obvious defect in his pec. If you have a long head of the biceps rupture, this is a very common injury. It's called a Popeye muscle, and other than being a minor cosmetic annoyance, it really has no treatment that's necessary for it. You really don't lose much strength as a result of a proximal biceps rupture, as opposed to a distal biceps rupture, which does have more of a problem. Impingement tests include the impingement sign, the impingement test where you inject lidocaine and the impingement sign goes away. The Hawkins sign shown here, which is the impingement reinforcement test. Again, if you do this test and then give them an injection, that goes away. You always got to look for weakness and atrophy, abduction, external rotation, looking for cuff pathology. And this right here is called the sign du clairon, or the hornblower sign, associated with a massive rotator cuff tear. This patient can't get it up, so to speak. So imaging then involves plain films, including an AP and an axillary lateral. And again, I can't emphasize this enough, including especially because of my recent experience. You always got to think about that. When you're looking at an AP, look for some subtle things, such as proximal migration of the proximal humerus, because that may represent an irreparable rotator cuff tear or rotator cuff arthropathy. Also beware of the missed posterior dislocation on the axillary lateral. So on the AP and axillary lateral, you're looking for these issues. There are special views available for instability, and the way you look for instability, you look for some type of view that will show you a Hill-Sachs defect and some type of view that will show you a bony Bankart lesion. The most popular views for looking for a Hill-Sachs defect on the OITE has been an anterior-posterior radiograph in internal rotation. The Stryker notch is also a helpful exam radiographically looking for a Hill-Sachs defect, but the AP and internal rotation has been the most popular as far as from a testing standpoint. The key is to get one view that shows a Hill-Sachs defect, one or the other. The other view you should get is some type of view to show you a bony Bankart, and that includes either a West Point view or a Garth or apical oblique view. So those are helpful additional tests. As far as impingement goes, the classic, of course, is the outlet view, looking for the 3 types of acromions that are either flat, curved, or in this case, hooked acromion, type 3 or hooked acromion, highly associated with rotator cuff pathology. CT tests can be helpful for fracture visualization, MRI looking for rotator cuff, and now with arthro MRIs looking at labral tears. Again, the gold standard has eluded us on some of these imaging issues. Arthroscopy, the key again, in this case, whenever you have an arthroscopic question, you've got to first think about what the nerves are involved here. If you use these portals, there's very little problem with that, although theoretically the musculocutaneous nerve could be injured if you strayed medial to the coracoid. And that's why these are lateral to the coracoid. Also, if you strayed with your primary viewing portal too far inferiorly, you could get into the quadrilateral or quadrangular space, which of course would injure the axillary nerve and the posterior humeral circumflex artery. So you keep this just 2 centimeters below the border, the posterior lateral border of the acromion, and that soft spot, and you won't have any problem. Again, posterior portal for viewing, the anterior portal for outflow and or palpation, a low inferior portal, that is an anterior inferior portal used for primarily arthroscopic stabilization procedures, Bankart repairs, just above the subscap. A lateral portal here for acromioplasties. This is the Navisor portal up here, used for slap tears occasionally. Also not shown here is a port of Wilmington, which is right off this corner of the acromion, used for posterior slap repairs. And now people are using another portal off the anterior edge of the acromion for rotator cuff repairs. So those are all portals around the shoulder, and again, knowing where those are. Two kinds of anterior shoulder instability: tubs, a la Matson, ambry. So tubs, traumatic unidirectional, has a Bankart tear, and those usually end up having surgery. And the ambry patient, atraumatic, multidirectional, bilateral, rehab, about 6 hours in ambry. And then failing that, the I stands for inferior capsular shift. You notice the I doesn't stand for shrinkage, okay? All right, now as far as for TUBS patients, the recurrence rate is age-related, and that's why the West Point studies have said, hey, we can do this acutely. Because the younger you are, the higher the risk of redislocation. In fact, in the West Point study, approaching 90% for 20-year-olds that are involved in their indoor obstacle course, the indoor obstacle course at West Point is a shoulder dislocating machine. And so if you want to do a lot of shoulder instability surgery, go to West Point. Now, as far as older patients, they don't have as much incidence of high recurrence, but the older patients, you got to worry about rotator cuff tears. So keep that in mind. If you're over 40 and you dislocate your shoulder, we don't rush in to fix your Bankart. Instead, we image you and examine you and make sure you don't have a rotator cuff tear. Physical exam, we've been over the apprehension relocation maneuver, and the initial treatment is probably for the boards, I would say rehab. And this issue about doing acute surgery, I would not answer that on the boards. Acute traumatic dislocations will have labral tears or Bankart tears. They may have a Hill-Sachs defect. They may have a greater tuberosity fracture. Again, anterior dislocation, greater tuberosity fracture. Posterior dislocation, lesser tuberosity fracture. Again, older patients will have rotator cuff tears commonly, and you need to rule this out. And they may also have nerve injuries, most often neuropraxias, which resolve with time, but you need to recognize them. The big controversy about open versus arthroscopic procedures, the key issue is that you need to repair the essential lesion, which is the Bankart tear, and it can be done equally efficaciously with either technique. The advantage of the arthroscopic procedure is there's less pain and it can preserve motion better. The other procedures for anterior instability, however, are not correct answers anymore and shouldn't be done from a practical standpoint. These include the putty plat or mag stack, which are basically subscap shortening procedures resulting in significant loss of external rotation in these patients and subsequent arthritis down the line. And so shortening the subscap is not an anatomic procedure, and answer anatomic procedures whenever you can on the boards. The Bristow procedure is another non-anatomic procedure, taking a piece of bone and putting it down in the area of the front of the glenoid. The problem when you do this, it doesn't always heal. There's screw problems, and there's instability, recurrent instability problems. If, on the other hand, you have a defect in the glenoid and you need to supplement bone, this may be an option, or a piece of iliac crest may be an option. Complications associated with instability, of course, the biggest one is recurrence. The subscap injury is an iatrogenic injury from post-op, and again, the lift-off test. And then you can get it too tight. If you tighten up too much, then you have loss of rotation, and the option for that would be a Z-plasty of the subscap. Posterior instability comes in a variety of flavors as well, and you have to be careful with patients with multidirectional instability. Classically, what happens with posterior instability is the patient will have a seizure or shock, and I stared at this book in Rockwood for many years as a resident until I finally figured this out. But what happens is that the internal rotators, all the muscles are stimulated by a seizure or a shock, as you can imagine. And the internal rotators are much stronger than the external rotators. So when you get shocked, the internal rotators overpower the external rotators and pull the shoulder out the back. And that's why that happens. And then what happens then is if you have a posterior dislocation, as I showed you on that one clinical picture, you'll have decreased external rotation. The key exam and the key diagnosis, and this is never done in any emergency room, is to get an axillary lateral radiograph. For some reason, emergency room doctors don't understand that you can get an axillary lateral radiograph even if the person is hurting. Okay, so no matter how much you tell them, they won't do it. So get it yourself. So if you see a posterior shoulder dislocation, reduce it, and those patients have a much, much lower recurrence rate than anterior instability. So it's ideal if you happen to get somebody smart enough to get an axillary lateral radiograph to reduce it right away, and you will do well by reducing it and immobilizing it, and they will have a low recurrence rate. Chronically, there's a variety of other things you can do. It includes a subscapularis transfer into that reversed Hill-Sachs defect if the defect's relatively small, less than 20% of the surface. You can do that with or without a piece of bone. If you do that with a piece of bone, that is a piece of the lesser tuberosity transfer in there, that's called the near modification of the McLaughlin procedure. If you do just the tendon, it's the McLaughlin procedure. You can also put an allograft in there, and that's recommended for up to 40% defects. If you have a defect that's 40% or bigger, then you need to do a hemiarthroplasty. Here's this case of that same gentleman I showed you before. 3 months after his injury, we finally got an axillary lateral radiograph in my clinic, and here we are, locked posterior shoulder dislocation. So in this patient, we had a defect that was 20 to 40%, and we put in a femoral head allograft that we matched, and it fit nicely in there with a couple of Herbert screws. Subtle amounts of posterior instability can occur in interior linemen and baseball pitchers. They may have pain when you stress them in this position. And the treatment then involves strengthening their external rotators, in this case the infraspinatus. And here's a swimmer with infraspinatus strengthening and went on to do well. If that fails, then you have to do some kind of posterior procedure involving the capsule. That involves classically a posterior capsular shift, but perhaps arthroscopic procedures may supplant that. But for the boards, I think the answer is still posterior capsular shift. And here's the way it's done. The intervals between the infraspinatus and the teres minor, you stay above the teres minor because below the teres minor is your old friend, Mr. Quadrangular Space. And then do some type of capsular plication procedure. Well, let's talk about our old friend, Mr. Shrinkage. Laser or RF thermal probe, shrinking collagen, breaks the covalent bonds. It's done about 70 degrees centigrade. The problem is, if you have multidirectional instability, then your failure rate approaches 50%. I don't know about you, but I have trouble convincing patients to go for procedures where the failure rate's 50%. The other issue is that there's been several cases of capsular necrosis reported with the use of thermal devices, and therefore for board purposes in particular, particularly recognizing who's writing these questions, they are the first ones that want to bash this, and it's the wrong answer. Rotator cuff disease presents with night pain. They may have a proximal biceps rupture as well. They have weakness with external rotation and abduction. They have positive impingement signs. They may have a large spur. They may also have proximal migration of the humerus. If you get an MRI, you may be able to, you'll see the cuff tear. What's equally important in the MRI is to try to figure out whether it's repairable. So you look at the muscle itself, if it's got fatty atrophy, degeneration, and significant migration of the proximal humerus, and the cuff is pulled back all the way to the glenoid, then you're not going to get a home run fixing that rotator cuff. And you may not be able to fix that rotator cuff. And the patient, more importantly, needs to be aware of that ahead of time. And so you counsel your patients accordingly, and that way they're not disappointed when you can't do it. Osteochondral means that there's an unfused ossification center, and it's usually between the mesa and the metaacromion, right in this area right here. The reason that's important is because that affects your results with a decompression. What happens is it actually causes a hinge effect, and it pinches and impinges upon the cuff. And so the controversy involves, what do you do about that? Well, the two options involve an aggressive acromioplasty or a fusion of the os with bone grafting and hardware. My experience with bone grafting and hardware has not been good, and therefore, from a practical standpoint, I do a more aggressive acromioplasty. However, for the board, I think these are both acceptable answers. Rotator cuff disease, again, continuing. Again, this is a continuum beginning with impingement and going all the way to rotator cuff arthropathy. Impingement, tendinitis, partial cuff tear, full cuff tear with retraction, full cuff tear with retraction and atrophy, proximal migration of the humerus, rotator cuff arthropathy. It's a large continuum. And so the cuff tear itself you can fix before it retracts too much with doing appropriate techniques. Again, arthroscopy is playing a big role here, and supplanting traditional techniques, which include open repairs and mini open repairs, and now arthroscopic repairs. The key is getting the cuff over to the tuberosity, and however you do that, I think, is acceptable. Of course, you have to recognize that open procedures have the risk of deltoid problems and deltoid detachment, and therefore, if you're doing open procedures, you need to go out of your way to put the deltoid back to the acromion through drill holes. The key testable questions on rotator cuff treatments and surgeries involve, no matter how you do this procedure, postoperatively, you don't want to do active motion, you want to do passive motion so your cuff has a chance to heal in. The other test question involves cuff arthropathy, and that's an end-stage arthritis and involves treatment with a hemiarthroplasty. The hemiarthroplasty does not take care of their motion or their strength. It does take care of their pain, and so that's important to tell the patient that. Arthroscopic cuff repair, there's a steep learning curve. Techniques and devices continue to appear and improve, and we've developed a whole new vocabulary that is not on the boards. Now, complications with rotator cuff disease also involve recurrence, the deltoid detachment we talked about, and this lateral acromionectomy, which used to be popularized, as you can imagine, had a lot of deltoid problems, and is mentioned only because if it appears on the board, it is the wrong answer. Calcific tendinitis associated with cuff disease, I think, and it involves some degeneration and calcium deposits in the supraspinatus near its insertion. Treatment is aspiration, debridement, and probably similar to decompression like we would do for impingement. Let's talk about 4 kinds of nerve entrapments. The suprascapular nerve can be trapped at 2 points. It can be trapped at the transverse scapular ligament as it goes into this fossa. If it gets trapped there, it involves 2 branches, the branch to the supraspinatus and the branch to the infraspinatus, and therefore you'll have weakness and atrophy of both muscles. If it gets trapped, however, at the sphenoid-glenoid notch after it's already given off its supraspinatus branch, it will only affect the infraspinatus, and therefore you'll have isolated infraspinatus weakness and or atrophy. This can occur as a result of a cyst that begins in the labrum and extends into the sphenoglenoid notch. The thoracic outlet syndrome involves compression of the brachial plexus and the subclavian artery and vein, and it occurs most commonly in females. There are several tests that reproduce this symptoms, including the Adson test shown here, where the pulse diminishes as the patient inspires and moves their head to the affected side. The right test, where you abduct the arm and the pulse goes away. If you have them go into a military brace, this may also affect their pulses. Or if you have them put their arms up and exert themselves with their hands, flexing and extending, it may reproduce the symptoms. And that, for good reason, is called the overhead exertion test. These 4 tests may diagnose impingement of the brachial plexus, subclavian artery and vein. You can get an arteriogram if you wish. And then you send them to your friendly cardiothoracic surgeon for them to take out a cervical rib or the scalene muscles. Quadrilateral space syndrome involves impingement of the axillary nerve. Again, this can be demonstrated with an arteriogram looking for the posterior humeral circumflex, which goes with the axillary nerve through the quadrangular or quadrilateral space. Both terms are used interchangeably. Also, it's helpful, as you'll see from our lecture tomorrow morning, to define the borders of the quadrangular or quadrilateral space. Other problems include neuropathic joint. As you heard yesterday, leprosy is one cause of that, but the most common cause of a neuropathic shoulder is syringomyelia, a problem in the cord, and the answer then is to get an MRI of the cord to diagnose that problem. Also, there is a problem with subclavian artery aneurysm in a few athletes with ischemic pain in pitchers. This involved one of the Yankee pitchers a few years ago, and they were able to take care of that problem. Muscle ruptures or injuries, the pectoralis major can get injured, and this was an interesting question I ran across on the fellowship examination. This entity, interestingly enough, only occurs in males. It has never been reported in females. So if you ever run across a pectoralis major injury in a female, then write it up because it's never been written up. And therefore, one of the test questions, one of the leaders was that it was a female athlete that injured it, and so that was the wrong answer because it's never been reported in females. This causes the axillary webbing I showed you, and then the treatment, of course, is to repair it. Subscap we've talked about at length, and I want to just emphasize how important that lift-off test is because you don't want to be lifted off your seat when you're answering the right answer. On to slap tears. The classic types involve 4 types described by Steve Snyder at the Southern California Orthopedic Institute. Mathod, who was at Job's clinic a few years later, described an additional 3 types. But the only important thing here is if the biceps anchor is truly unstable, if it moves and it's unstable, and it's not just an anatomic variant, then the anchor should be repaired. If there is fraying or flaps or what have you, then like anywhere else with an arthroscope, if you have fraying and flaps, you simply debride them. So the key issue involves the bicep anchor, and that's where all the controversy is, and how you diagnose it, how unstable it has to be, what is an anatomical variant that's normal, etc. And the controversy rages. Back to internal impingement, which we discussed before. The arm is in extension, abduction, and external rotation. So if you're sitting there on your exam and they're asking you what the arm position is when you're trying to answer this question about internal impingement on your boards, then do what this baseball pitcher is doing, and the test proctor will probably think you need to go to the bathroom. And therefore, again, you impinge the posterior cuff and labrum during the late cocking phase and early acceleration phase, and the treatment is to try to stretch out the posterior capsule. Failing that, then you can do an arthroscopic debridement and probably some type of plication procedure, and this may turn out to be one place where you can do that with shrinkage. So there may be a shrinkage role someday, who knows. The other thing about internal impingement is it may be associated with thrower's exostosis, which means nothing more than a little osteophyte associated with this problem. Let's take a look at a couple of arthroscopic findings. This is a drive-through sign. As you drive through the shoulder is very loose, and that shows you have anterior instability, confirming your clinical diagnosis. Here, indeed, is a true slap tear posteriorly. You can see that this is disrupted back in the back of the glenoid. Here's the front of the glenoid. As you externally rotate and abduct the arm, it peels back even further, suggesting that you have instability there. Partial cuff tear is very common and can be debrided accordingly. Moving on. Acromioclavicular separations, the most important testable issue here is that even a type 3 injury where both ligaments are disrupted, that is the coracoclavicular and coracoacromial, in most locations and therefore in the boards can be treated non-operatively. There was some controversy several years ago about treating type 3 injuries in laborers and athletes, but if you've ever been to a dressing room for a professional hockey team, you'll see that that's not the case. They don't treat those, and they do just fine. And therefore, up to type 3 can be treated non-operatively. Type 4 injuries involve a puncture or displacement into the trapezius muscles, and classically those need to be reduced and treated. Type 5, and most people don't understand what a type 5 truly is, but what it is if you measure side to side and it's displaced more than 100% of the other side, that's a type 5 injury. And so most people just kind of throw their x-rays up and look at them and go, oh, it's type 3 injury. But you need to measure the distance from the coracoid to the clavicle and compare side to side. If it's more than 100%, it's type 5. And type 5 are treated operatively. And so therefore, rather than just calling everything type 3, oh, AC separations do fine, really measure it and recognize there's a lot of type 5s that are being not treated. And those classically buttonhole through the deltoid trapezial fascia can become subcutaneous, and most people recommend fixing type 5 AC separations. A type 6 AC separation has only been seen 1 or 2 times in the history of orthopedics, and therefore I wouldn't worry about it. Distal clavicle osteolysis and weightlifters, pain at the end of the clavicle, cystic changes, osteopenia. Tell them to change the position on their bars, to reduce their rates, and then more often than not, they're too stubborn and you have to do a distal clavicle resection, which can be done either arthroscopically or through a small incision. AC arthritis associated with impingement. They have pain with cross-chest adduction, osteophytes, etc. Treatment, activity modifications, injections, and then more often than not, when you're doing a chromioplasty, you go ahead and do a distal clavicle resection. Sternoclavicular injuries, the key for the boards in this case is if it's acute, you can try to reduce it. If it's chronic, you should ignore it. That's the key issue here, even though it bothers them. CT scan is most helpful for diagnosis, and of course, there's major structures with Latin names right immediately below where you're working. Another test question for boards: avoids pins and hardwares for fixation because they migrate, and all kind of stories about people having PEs with pins and in their heart and everything else, so it's bad news. Adhesive capsulitis involves an autoimmune disorder that causes capsular constricture. They lose the axillary recess on arteriogram, arthrogram, and the treatment of the frozen shoulder is not manipulation under anesthesia for the first time, and for the board answer, it is rehab, 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 and then maybe manipulation under anesthesia. But they'll suck you in trying to get you to manipulate this on the first visit, and don't do it. Scapular winging is based upon where the inferior border of the scapula goes. If the inferior border goes medial, then that's medial winging. If the inferior border goes lateral, then that's lateral winging. The most common, of course, is the inferior winging because there is an injury to the serratus anterior, which is the long thoracic nerve. Now, that can occur with backpacking or thoracic procedures and weightlifters with traction injuries. And the treatment then is rehab, 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 waiting for the nerve to come back, which will take 6 months because it is the long thoracic nerve. And then if that fails, then and only then do you consider pectoralis transfer to try to fix that. So medial winging, serratus anterior, long thoracic nerve, rehab, 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 and then pec transfer. Now, lateral winging is less common. Involves the trapezius for cranial nerve 11. Somebody's doing a neck dissection and got into the cranial nerve 11, and therefore they injured the trapezius muscle. Treatment: trap strengthening, nerve exploration, scapulothoracic fusion, or the so-called Eden-Lang procedure, where you take all the muscles that insert on the medial border of the scapula and you move them laterally. Snapping scapula. You see these about once a year. Patients come in and demonstrate a concert piano or concert noise from their snapping scapula, and you got to try to figure out whether there's an osseous lesion. And so you go on this wild goose chase looking for an osteochondroma, and rarely do you find one. And then you need to figure out what you can do about that, and that typically involves anti-inflammatories, maybe an injection, rehab, 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 and then if you get sucked into it, you got to figure out how you're going to try to take care of this patient operatively, and it's never easy. And some people have described resecting the superior medial angle of the scapula, and that can be done either with an open procedure or maybe arthroscopically. And recently arthroscopic procedures have been described for this, but there's no long follow-up, and it's not the right answer for boards. I've done a couple scopes in this area. You go until you see red or bubbles. As far as overuse injuries in the shoulder, is this disorder little leaguer shoulder, which is basically a Salter-Harris 1 fracture of the proximal humerus, occurs in little leaguers who throw too much as pitchers, and that's why we've limited the amount of innings that little leaguers are allowed to pitch. And therefore, the treatment, of course, is nothing more than activity modification. Fractures of the proximal humerus classified by Neer, and you've already heard about this, about the 4 types, the 4 components: greater than 1 centimeter displacement, or angulation more than 45 degrees. Treatment: closed, percutaneous, open, or hemiarthroplasty. Obviously, you try to go with the lesser first. So the answer is fix it if you can. Here's this big head component came off. We're able to fix it with an open technique here, and somehow we're able to put that back on the cone and fix it with a percutaneous technique here. So those are 2 success stories. And sometimes, however, you can't, and then you've got to do a hemiarthroplasty and put those tuberosities back down. Clavicle fractures. Operative indications involve open fractures, subclavian artery injuries, floating shoulder, in which the clavicle and the scapula, neck have fractures. And this is an area of controversy because there was a recent paper suggesting you don't have to do this. However, that paper is pretty recent, and therefore I think this is still the answer for the boards. You should fix type 2 distal clavicles that are displaced significantly and symptomatic non-unions. Now, this is the board answer, so memorize this, but a trend is occurring in orthopedics where people are starting to fix more clavicle fractures. And for your own clinical practice, you need to be aware of that. And there's new techniques, including intermedullary fixation, that make that more possible. But for the boards, here's your answers. Medial clavicle fractures, here's a case where this patient had significant compromise or impending compromise of the subclavian, and so we fixed that accordingly. This obviously requires a little care when you're trying to reduce this. Non-unions, if you have significant shortening and displacement, maybe paratroopers may evolve to ORF with intermedullary devices. Distal clavicle fractures, these still recommended to be treated operatively. Moving on to arthritis, patients have pain, crepitus, narrow joint space osteophytes, typical goat's beard deformity on the bottom of the humerus, treatment supportive, and then finally arthroplasty. Rarely do we have to do fusions. So let's move through some shoulder questions real quickly. Again, we'll concentrate on odds and save the evens for later. As far as shoulder procedures, don't get MRIs and arthroscopies until you figure out what the diagnosis is. Don't do non-anatomic procedures. Don't manipulate frozen shoulders without trying some rehab. Again, steroids are pretty much the wrong answer on the boards unless you've tried other things. And don't treat most clavicle fractures. Don't put pins or K-wires around the shoulder, especially the sternoclavicular joint. Moving on, then, 38-year-old woman, constant pain in her shoulder as a result of MVA, restriction in external rotation. Radiographs are not available. Well, what do you know? And films taken in the ER were normal by report. Well, guess what they didn't take? Axillary lateral. Unfortunately, occurs too common. Which of the following conditions of rehab program for shoulder instability result in a satisfactory response? How many R's are there in Ambry? Number 5. Most common complication with anterior dislocation of the glenohumeral joint is 19-year-old, 90%. Patients older than 50 with shoulder dislocations, they can have nerve injuries up to 50%. We talked about that. A 56-year-old laborer with a subcoracoid dislocation fell off a scaffold. He can't move his arm now. Why? Because he's probably got a massive cuff tear. Right-handed 35-year-old man had a putty plat, too bad for him, and now he has loss of external rotation. What's he got? Not sure about that. We'll have to go over that one again. All right, 13, conservative management of recurrent unidirectional posterior shoulder instability emphasizes strengthening of posterior instability. External rotators, infraspinatus. 15, immediate post-op management of the repair of large cuff repairs should include, whether they're done arthroscopically or open, they both need to have limited passive range of motion, not active because it'll pull it off. 17, 72-year-old woman, massive cuff tear, arthritis. What can we do for her? Why don't you do a total shoulder? Because it'll rock the glenoid component off, and therefore you do a hemiarthroplasty. Medial dislocation and long head of the biceps. What did we injure? The subscap. We talked about that. 21, Carpenter, anterior sternoclavicular joint. We can try to reduce that, but chronically we're not going to. 4 weeks ago, it's chronic, okay? That's why we treated him symptomatically. 32-year-old Carpenter, diffuse pain, limited overhead motion, fall on his outstretched arm. Exam reveals medial scapular winging. Medial scapular winging, they gave you a break because they gave you the long thoracic nerve, and the treatment after 2 months is just waiting for a few more months and see if it returns. 25, lateral scapular winging. Trapezius. 27, little leaguer. Little leaguer, what does he do about little leaguers? Just tell them the activity modification. Tell them to pay attention to the rules. 17-year-old closed clavicle fracture. He's got a symptomatic non-union. What do you do about that? Do ORIF. Okay, let's move on then quickly because we're going to have to move along. We're going to skip the questions in the next sections because we're going to get done by 9:30. So distal biceps avulsions involve loss of supination, pain, weakness. You may see a defect in here, and the treatment is to repair that. If you neglect it, you lose supination strength and flexion strength. Lateral epicondylitis involves the extensor carpi radialis brevis, and the treatment is non-operatively until everything has failed, and then you can consider debridement. Medial epicondylitis is similar, except it involves the pronator teres and FCR. The collateral ligament injuries, this is a review for you, so I'm going to go quickly because you've already covered this. Again, the anterior band is the key to reconstruction. On the lateral side, the key is to worry about the lateral ulnar collateral ligament. This is diagnosed with the pivot shift, and the treatment is lateral ulnar collateral ligament reconstruction. Pitcher's elbow involves overuse and excessive loading. Medially it's tension, laterally it's compression, and then you get an osteophyte posteriorly. The treatment then for this early arthritis involves activity modification and then excision of osteophytes. That can be done arthroscopically, or you can do it with this outer bridge Kashiwaguchi, which basically you cut a hole with a Clower drill, and from the back you access the front. With pediatric injuries, you can get medial epicondyle stress fractures. Again, all of these are related to activity modifications. They'll go away. You can also get Osteochondritis Dissecans of the capitellum, which involves changes in the capitellum. And if they're loose bodies that are symptomatic, then you sometimes have to arthroscopically debridement. This is different than Painter's disease, which is osteochondrosis, which is a self-limited disease in a younger patient. Again, elbow arthroscopy, there's a lot of nerves across the elbow, so they're going to ask you about nerves and their injuries. The two that they ask the most include the anterior medial portal and its wrist with the medial antebrachial cutaneous nerve, and the anterior lateral portal, which is very close to the radial nerve. The most safe portals are these far proximal portals, which are 2 centimeters proximal and to the epicondyles and just anterior to the septum. And that's the portals I like to use with the patient prone. Wrist and overuse injuries include Decker veins or various other tendinitises, include intersection syndrome, and these are treated with activity modifications, injections, and occasionally releases. This is beyond the scope of this talk, but to recognize that wrist instability occurs as well as fractures, and you need to look at the radiographs carefully and do stress radiographs as indicated. Also, hook of hamate fractures occurs commonly in sports injuries, and you need to get a carpal tunnel view or a CT scan to make that diagnosis. This can occur in golfers. TFCC injuries also with a lot of repetitive use sports injuries. They're classified by Palmer based upon their location and whether they're traumatic or degenerative. Wrist arthroscopy is defined based upon the extensor compartments, and the typical viewing portals include 3, 4, 4, 5. And then mid-carpal portals are important also. I'm told by the hand guys that you have to view it both from the radiocarpal and mid-carpal portals in order to confirm a scapholinate injury. And so wrist arthroscopy allows you to view all of these spaces. Hand injuries, again, have been covered, but I want to emphasize the sports injuries, including the jersey finger, which is an FTP avulsion. It's important to know where it's avulsed to so you know when to repair it. If it stays there locally, you can delay it. If it goes to the palm, then you need to do it earlier because there's no vascular supply. This Leddy-Packer classification seems counterintuitive to me, but just know where it is. Skier's thumb, ulnar collateral ligament. There's a center lesion here because the aponeurosis covers it. You need to incise it and repair it. Boutonnieres can occur when you miss a PIP injury because you should splint these initially in the extension for 6 to 8 weeks. That involves just the PIP extension and not the DIP. Volar plate injuries can occur following dorsal dislocations. You should buddy tape these patients if they're unstable on radiographs. Then you need to do a extension block splint. Look for the so-called V sign of light. If there's a V sign, it means that the reduction is incongruous and requires to have an extension block splint. That is, you flex it down until you have a congruous rotation on a lateral radiograph. Start there, gradually increase it on a weekly basis. The so-called mallet finger or baseball finger involves an injury to the dorsal extension of the extensor on the distal phalanx. You splint these in extension for 6 to 8 weeks, and then an additional 6 weeks or so at night splinting. You can tell whether they're compliant or not based upon whether their creases go away. We're going to skip the upper extremity questions. I'm going to leave this to you because they take some time and because also we have covered these in the hand section. And then we're going to move on to the spine injury section, emphasizing once again the key issues that are sports related. So let's move to head and spine injuries. Concussion means transient impairment of neural function. You don't have to have loss of consciousness to have a concussion. There are various grades, and it depends upon whether you have loss of consciousness. Loss of consciousness is a big red flag, and you probably should get a CT scan. And loss of consciousness requires the patient to be delayed from return for a month. Unfortunately, those rules aren't always followed in the NFL. So you can't return to play if you have loss of consciousness, if you have symptoms greater than 15 minutes, if they recur after exertion stress test, if you have amnesia, but particularly retrograde amnesia, and if you had a prior concussion. You've got to worry about second impact syndrome and repetitive effects. Second impact syndrome means if you have a second, often minor blow to the head after initial symptoms from the head injury, you can have a 50% mortality rate associated with second impact syndrome. This occurred in the NCAA guidelines to managing athletes, and so therefore I would recommend you not allow patients to return to play with symptoms, because if you happen to be unlucky enough on the coin flip, you're going to be in trouble. Now, cervical spine injuries occur as a result of axial load. You should always leave the helmet and pads on during transport, and those are the questions that are asked there. Burners and stingers come in a variety of fashions. These are self-limited, but as you get into quadriplegia, obviously there's a lot more concern. Stenosis is a relative thing, and this is only a helpful adjunct to look at the Pavlov ratio, but it's not necessarily the definitive at all. You need to look at several other issues, including potentially MRIs. If you get acquired stenosis, that's called spear tackler spine. You try to convince the kids not to tackle with their head down. If they don't listen to you, then they're disqualified from playing football. So functional stenosis is what we use as a criteria rather than the Pavlov ratio these days, and that depends upon soft tissues, dynamics, and the size of the cord, and that's best assessed using MRI criteria. Burners present with a dead arm. The guy runs off the field like this. Wait till it gets better, completely better, with all strength before you allow him to turn back. Obviously, it's very common. It involves a compression of the roots or the brachial plexus itself that's stretching or compressed. And burning pain, non-dermatomal, unilateral, allow them to have full, pain-free cervical motion and no tenderness to palpation, and allow them to return after it goes away. Palpate the neck, check the motion, and then try to see if it hurts them. When you do that, it's self-limited. It usually resolves, and you can get them back to play. However, several sideline evaluation red flags include whether it's bilateral, if it involves their lower extremity, if there's persistent burning, painful range of motion, or tenderness, then those patients need to be pulled from the game and have a more careful evaluation. If their burning resolves, their neuroexam is normal, they have negative provocative tests, and they have painful motion, then they can return. And then you should try to strengthen them, considering using shoulder pads and neck rolls and various other proper tackling techniques. Moving on to cervical sprain, this usually is a direct collision injury without radiation of the arms. This is a relatively high re-injury rate, and you need to be aware of these injuries. You immobilize them if necessary. If there's any question, and you get x-rays, and then you rehab and they return to play when they're pain-free, normal range of motion, and full strength. As we get into more serious injuries, these include transient neuropraxia. Usually they resolve in 10 to 15 minutes, sometimes take longer. And these can cause patients to lose lordosis and have other problems. And then as we go along with quadriplegia, this is a permanent cord injury. Fortunately, it doesn't happen very often, but it's a devastating injury we see on the news occasionally. You do appropriate ABC management on the field. You immobilize them. You leave the helmet and shoulder pads on. You cut the face mask off, get them to the hospital, and there they do the spinal cord protocol, and under a controlled setting, remove the helmet and shoulder pads. Moving on then to lumbar disc disease, this has been covered extensively, and the bottom line is I wanted to tell you in adolescent athletes, they may have a paucity of clinical findings. Spondylolysis occurs commonly in athletes, particularly gymnasts and weightlifters. You can get oblique x-rays looking for the Scotty dog, and then bone scans and CT scans are also helpful. If you have a slip, if it's a grade 1 or 2 slip, that is less than half of the body width, then you can allow them to have unimpeded sports participation. If, however, they have a grade 3 or 4, then they need to be excluded from sports participation. Once again, I'll leave you with the questions to do on your own, and we'll go to the final section. This section is primarily for those of you who are going to be in the training rooms, and it won't be a lot tested on the boards in this, but I want to give you a little insight because this may even just be at the high school level, and so it's important for you to understand some of these issues. One of the newest issues is this Privacy Act business, and you have to be careful about that and releasing information. You also have to be able to work with the trainer, and although most of the injuries are musculoskeletal, they're only a portion of the athlete's health care needs. And so I feel like the orthopedist is ideally suited to be the head team physician, and we encourage to try to do that whenever possible. A lot of places have gone to having primary cares as the head guy. We certainly need to have primary cares helping us, but we need to try to hold on to the role of the head team physician whenever possible. So some of the issues involve heat illness, and these are problems that aren't orthopedic per se, but something we have to be aware of, and you need to recognize this and anticipate how you're going to do about this, and they come in a variety of flavors. The bottom line is evaporation of sweat is the heat dissipation, and you need to acclimatize accordingly. As you get temperatures that increase, then you need to have different requirements for your athletes, and in Texas that means you can't ever practice outside in the summer according to these criteria. But you also need to weigh your patients before and after each exercise day and make sure they don't lose more than 5% of their weight per session. Especially attention to obese patients, those in poor physical condition, those go hand in hand. If they had a previous history of heat illness, or if they're on creatine. Heat cramps, muscle groups of the legs can cramp up because of salt and water loss, and the treatment then is to give them some salt water with a diluted oral solution. Or we just give them a handful of table salt on the sidelines with some water, and it seems to work pretty well. Heat syncope gets low pressure and fainting from blood vessel dilation. Again, have them lay down, rehydrate them, and they can get back. We're going to go to varying degrees, increasing degree heat exhaustion, temperature up to 104, significant problems but no neurologic changes. You can still cool and get fluids and have them rest. And then heat stroke, which is the worst, of course, is a medical emergency. Goes over 104 core temperature. You need to rapidly cool these people. Heat stroke can be either classic or exertional and includes a lot of sweating, and you need to get these people to EMS as well. Now, ergogenic drugs are important for the team physician as well, and these include effects like testicular atrophy and alopecia, which are irreversible. That's probably not a good combination if you're a single person. Growth hormone is being abused more and more, and the side effects include hypertension and gigantism. Creatine is a popular supplement. The problem is it can cause heat cramping and hydration, and what it does, creatine basically adds the P for the ADP to ATP effort for anaerobic efforts. Supplements continues to rise shortly. Be aware of this and be aware what your athletes are taking and look at the bottle if they allow you to. Once again, creatine pulls the water from the blood vessel, and that's why there's a hydration risk. Stimulants, you hear about these all the time in the Northwestern disaster where the guy was taking all these ephedra, and therefore you need to look at the bottle, you need to be careful, and you need to warn your student athletes. Other supplements I throw in just because they're kind of sports related, that is the various glucosamine chondroitin sulfates. They provide building products for cartilage synthesis. Whether they work or not is some question. but some people seem to have some benefit from them, and there are some studies showing some efficacy in some studies. The problem is regulation, and they're not all #1 doctor recommended, obviously, but they would lead you to believe they were. Hyaluronic Synvisc increases viscosity, has a transient effect for arthrosis, but is very costly. Some patients actually have told me about this treatment here. Steroid injections, again, don't do it into tendons. They can cause skin changes, and you tell your patients they can affect glucose levels in diabetics. Various kinds of exercises include isotonic, where there's constant resistance, isokinetic, constant velocity. Weight training increases the mitochondria and capsular density and thickening in the connective tissue. This is an area they ask a lot about on various tests. 3 kinds of exercises. The sprinter uses the anaerobic ATP pathway for short sprints. Glycolytic for intermediate periods until they reach the lactic acid threshold, which is commonly asked. And then aerobic for long-term sustained training. And make sure you know where those 32 ATPs go on that Krebs cycle. Just kidding. Now, as far as exercise, there's plyometrics, which is good for sports-related testing, and also this has been effective in teaching our female athletes to reduce our risk of ACL injuries. There's also PNF, or proprioceptive neuromuscular facilitation, which involves a lot of increased stretching exercises. Prophylactic knee bracing and ACL, PCL, no proven efficacy, except for recently in skiers there was efficacy reported up the mountain. For MCL injuries, hinge braces may reduce the MCL injury rate in linemen and linebackers, but not other positions. A variety of viral infections can show up in the training room. We'll go quickly through these. These include the common cold, which involves the rhinovirus. Influenza, a little more significant. Fevers and chills, again, supportive treatment. Pharyngitis, Coxsackie or adenovirus, supportive treatment. Make sure you don't have a bacterial pharyngitis. Meningitis is a big problem, and it involves the enteroviruses and requires a CSF tap. Mono is important because the spleen enlarges, and if the spleen enlarges, you need to protect your athlete against blunt trauma, and therefore no contact sports for 4 to 5 weeks after they've been diagnosed with mono, and also they demonstrate no splenomegaly, which is typically tested with ultrasound. Cytomegalovirus, fever, fatigue. You can do a complement test. This is a self-limited problem. Viral gastroenteritis, we'll say enough about that. Skin infection involves commonly herpes in wrestlers, and they take various forms of acyclovir, antiviral treatment. You've got to treat them prophylactically and ahead of time because otherwise they'll be excluded from competition. Myocarditis, chest pain, myalgia in athletes. You can get an echocardiogram, and you need a cardiologist to help you figure this out. Post-viral fatigue syndrome can cause prolonged recovery and muscle fatigue in some athletes. HIV is not grounds to keep our athlete from competition. Hepatitis can occur from blood contact. There's a needle stick risk. And the incubation is 60 to 90 days. We're all hopefully vaccinated with the Hep B vaccine. Unfortunately, there's no Hep C vaccine, and so we're all dreading the career-ending needle stick that's could be around the corner. Sudden cardiac death includes most commonly hypertrophic cardiomyopathy, coronary artery disease in older patients, and this entity called comatocortis, which means basically a baseball or a hockey puck slams you in the chest and you are dead. Regardless of whether or not they have resuscitation available, this is a fatal injury. So you should always get cardiac consultation if patients are lightheaded after exertion, if they have a murmur, if you're lucky enough to pick that up, and especially a systolic ejection murmur that increases with Valsalva. Fortunately, you don't have to hear that in order to answer the test question. Exercise-induced asthma involves coughing, shortness of breath, and wheezing. Treatment with beta agonists and steroid inhalers. Blunt injuries. The most common blunt injury, and this is asked all the time in the OIT question, the most common blunt injury is the kidney because there's 2 of them. So the second most common is the spleen, which is common in football players. Pneumothorax, the sideline question is involved putting a large bore interthoracic needle in the second intercostal space. Kidney injuries, if you have hematuria following a blow to the flank, then you need to get a urologist involved and make sure that they take care of these devastating injuries. Eye injury, the key is prevention, wearing glasses or protective eyewear. If you have blood in the eye, you need to send them to an ophthalmologist. Check their vision, look for visual acuity, look for these other issues including photophobia and double vision. If you have a testicular injury, usually a result of a kick, you can rupture the outer layer and you can do ultrasound evaluation for that. If you have a paired organ that is missing, it is not grounds to be excluded from competition. Even though if they injure the other organ, the other pair of that organ, they won't be able to survive or function very well. It doesn't matter. You cannot exclude them from competition if they only have one organ. That's the American Disability Act. The female athletic triad involves menstrual dysfunction, disordered eating, and decreased bone mineral density. If you can get birth control pills and counseling, then it can often solve this problem. The other issue of female athlete involves the Title IX issue, which is an area of significant controversy in the country right now, but they need to have equal access to athletic events and athletic participation. ACL injury, we're trying to solve this problem with working on jump training, and a whole variety of other studies are being undertaken as well. Stress fracture we've talked about, some of the common locations here. And that leaves us with some team of questions, and then we've already been through this, but the bottom line is don't do isometric exercise and don't delay treatment on the field. I'll leave you to go through these questions on your own. And we're getting towards the end here, and I appreciate all that you've done. I appreciate your participation, and I wish, of course, everybody the best of luck.